Dr. Maipal.
Good evening, Dr. Maipal, sir.
Hello, Dipti.
We are live.
Thank you. Respected seniors, colleagues, and my dear friends, welcome to this very unique and very interesting AIOS ARC webinar on refractive surgery. First of all, a very big thank you to our President AIOS, Dr. Harbanshlal sir, and our ARC chairman, Dr. Prashant Babankule, who has yet to join because he is still traveling, for being the guiding light for all our AIOS ARC webinars. Friends, in today's world of refractive surgery, we have a very wide spectrum of refractive procedures, right from advanced surface ablation to Lasik, femto-Lasik, Smile, the new procedure, Silk, and Phakic IOLs. When to operate, when not to operate, which patients to take up, which to refuse, what options to give to our patients, how to manage complications. These are some of the issues that we as refractive surgeons face on a day-to-day basis. And today we are blessed and honored to have with us an expert panel who are so experienced and who are pioneers themselves in refractive surgery to guide us through all these questions. So I'd like to welcome one and all here. Welcome to our esteemed panelists as well as our esteemed speakers. So our first panelist is Dr. Maipal Sachdev sir. He is the medical director, managing director, and chairman of the CFS group of hospitals, our past president of AIOS, brilliant surgeon, and the guiding light through all our COVID years to AIOS. Welcome, sir. Our second panelist is Dr. Jeevan Titial sir. He is the chief of RP Center and the head of the cornea and cataract refractive surgery services. Welcome to you, sir. Brilliant surgeon and has always been guiding. Ramurthy ma'am, welcome ma'am. The past ARC chairman herself, and she is the medical director of the Eye Foundation group of hospitals, Coimbatore, and very brilliant surgeon and a great academician. Thank you, ma'am, for being here. Next, we have Dr. Gaurav Luthra. He is the managing director of the Drishti Eye Center at Dehradun, a very brilliant surgeon and a lot of experience in cornea cataract refractive procedures. We also have with us our very own all speakers here, so that and Dr. Amrish Sarik sir. Sir, he is the director of the Vision Laser Eye Center in Pune, a very experienced surgeon, cornea cataract refractive surgeon, and has been one of the pioneers in LASIK surgery in India. Thank you so much for being here. We also have today the hot debate session, which we'll be starting with. In our first debate, we'll be taking up Dr. Shreyas Ramamurthy and Dr. Pranita Sahai. Dr. Shreyas Ramamurthy is the medical director of the Eye Foundation group of hospitals and a very young, dynamic, brilliant surgeon. He'll be speaking on topo-guided regularization with CXL in the scenario mild keratoconus with decentered cone. And against him would be Dr. Pranita Sahai, who is a consultant at CFS Eye Hospital. Yeah, please welcome.
She is assistant professor at Guru Nanak Eye Center now.
And an assistant professor at Guru Nanak.
No, not and. She is now at Guru Nanak Eye Center.
At Guru Nanak.
Nanadad Medical College.
Okay. Welcome to you both. Dr. Shreyas.
Yes, madam.
You can please start your presentation.
Thank you, madam. At the outset, I feel thank you so much for inviting me to this ARC webinar and for the opportunity, madam. And at the outset, I feel bad for Dr. Pranita because she has a very difficult topic to defend in this era of topo-guided PRK in keratoconus, in mild KC, whether it is centered or decentered. I think we'll all do mostly TGPRK at all times, but I'm very keen on hearing what she has to say or when she would do Intacs as well. So let me quickly run through why I would do topo-guided PRK only, and before that, give a basic few aspects of why we need TGPRK. Essentially, we were doing CXL with contact lens as the primary option for keratoconus, but not everybody is contact lens tolerant. And if we can reduce the amount of irregularity with a procedure like topo-guided PRK, then it improves the overall function and their visual acuity, and really helps them to give a certain degree of spectacle independence as well as improved spectacle corrected visual acuity. So what TGPRK actually does is really, in a very, very predictable and repeatable manner, it helps us give a much better regularized anterior corneal surface. So essentially, we are flattening over the apex of the cone, as you can see here, and causing an ablation in the mid-peripheral zone, which steepens the cornea anterior to it. So essentially, you are steepening a flatter area and flattening a steeper area, giving a more regular topography. This is essentially what we are doing with topography-guided PRK. Now, we do it in mild to moderate KC, as the debate suggests. We generally ensure that there is a minimum thickness of around 400 to 450, and we don't ablate beyond 50 to 60 microns. However, if you have good corneal tissue, there have been studies which have shown, which have done up to 80, but we generally stick to 50 to 60 micron. You can play around with the optical zone size from 5.5 to 6.5 based on the amount of higher order aberration you want to correct, the amount of astigmatism that you can debulk, and the pre-op pachymetry which is available. Remember, we are not aiming at emmetropia. We are aiming at ensuring we improve the functional quality of vision. And along with that, you also should remember that with the CXL itself causing a slight bit of flattening, you would do well to undercorrect these patients, ensure that they never shift into hyperopia, keep them in the myopic range itself. Centered versus decentered, as long as you get a repeatable topography, you have good, decent spectacle corrected visual acuity, 612 or better, and usually that would be the case with mild to moderate keratoconic patients. Whether it is centered or decentered actually does not alter the outcome, and I'll show some examples as well. If the outcome is slightly better with centered, but it works very well in decentered cones also. Same with Intacs. It works better with centered, little less so with decentered, but it can be used in both. Same goes for TGPRK, but in a more repeatable manner. Topo-guided treatment is the key, but just in case you don't have access to a topography guided laser and you have a laser only which does conventional treatment, even that has been shown to have efficacy. Although topo-guided treatment is preferable, but even a Wavefront guided treatment can also be done in a repeatable manner to ensure good results. These are just some example of patients. You can see that there is a significant improvement in the curvature irregularity, reduction in the IS asymmetry from about 8 diopter to just 1 diopter. Patient's BCVA has improved from 612 to 6.6. Another instance where you can see BCVA has improved, UCVA is where you get significant improvement from 624 to 6.9. Asymmetry comes down, you have a much more symmetric anterior cornea. In some central nipple cones, the cone disappears altogether, and you can see an excellent improvement. Decentered or centered, you have very, very good visual and functional improvement with topo-guided PRK, because essentially you can alter the treatment plan, center the ablation over the area of the apex. You could do an additional PTK in certain platforms like the Schwinn-Damaris. You could do an additional PTK in that zone of steepening and further induce flattening in that area without consuming too much tissue. So much variety is available now with topography guided treatments that almost any extent of cone can be corrected. Intacs results, however, while this is what published literature says, 3 to 5 diopter of flattening, 1 to 2 line improvement in BCVA, unfortunately, this is not consistent. You have patients who have improvement, but you also have a subset of patients who have loss of lines in BCVA. And since we are talking about mild to moderate keratoconus, I'm highlighting this particular paper. It's a large series of 620 eyes which have analyzed the results, and they have looked at grading as per visual impairment. So you have divided into group 1 to 4 based on the amount of CDVA that the patient has. So it's not just about centered or decentered, but the best spectacle corrected visual acuity the patient has. And what they found was that while the gain in lines were more in the more advanced degree of patients, which is expected, somebody who has a more advanced cone will have a greater gain. But what is more important is that the loss in lines. Nearly 40% of patients who had mild level of keratoconus, lost lines of BCVA. And that is predominantly why even in our Intacs criteria, we start saying that patient with a BCVA of less than 612. The reason is that is the subset who actually can consistently gain lines of visual acuity. In a patient who has a very good spectacle corrected visual acuity, they are already well adapted to their cone. Shifting the cone, altering the curvature actually induces a drop in BCVA when you're doing intracorneal ring segment. This kind of loss in BCVA you almost never see in topography guided treatment. Their BCVA will either improve, you will always get topographic regularization, but along with that, some of them there'll be a significant improvement in BCVA, some of them a slightly lesser improvement in BCVA. But loss in lines of BCVA is something which you almost never see unless they have developed scarring, which is actually a sequelae to CXL and not due to topography guided treatment. But this can happen with intracorneal ring segments. And as you can see, cumulatively between 1 and 2, this is what I was saying, loss in 1 line and loss in 2 lines are significantly higher in the early grades of keratoconus, anywhere ranging between 5 to 40%. So to conclude, topography guided treatment is a promising procedure in early mild to moderate keratoconus, can give rise to some degree of spectacle independence, but more importantly, gives rise to an overall better quality of vision. Thank you so much for that.
Thank you, Dr. Shreyas. Great presentation. We'll take the next contestant and then we'll have a discussion.
Sure.
So, welcome Dr. Pranita. She's the Assistant Professor, GNEC, Maulana Azad Medical College, New Delhi. Ex-Senior Resident, AIMS, Delhi. Ex-Assistant Professor, Lady Hardinge Medical College of Medical Sciences, Delhi, has 87 PubMed publications and has authored a book and 27 book chapters, and has received the Best Scientific Paper Award. Thank you. Over to you.
Thank you for that introduction. And yes, Dr. Shreyas, that was a really wonderful presentation. You've made my talk difficult, but as a cornea person, never, ever that I will ablate a keratoconus eye and make it further thin is not something that I'm ever going to agree to. So yes, I'll be presenting upon Intacs with CXL and mild keratoconus with decentered cones. So moving on to my slides. So as we all know, the basic idea of treating any keratoconus patient is one is to stop progression, for which CXL is needed, and visual rehab, which can be either with conservatively with contact lens or with surgeries, as we are discussing today, that is Intacs or Topo-guided PRK. As we all know again, that Intacs is a US FDA approved treatment for keratoconus, works by arc shortening effect and has advantages of improving UCVA, CDVA, and the manifest refraction in these patients. However, as is true for all surgeries, there are certain inherent disadvantages, one being loss of UCVA and CDVA in advanced keratoconus. And also sometimes a ring explant may be needed. So first we need to basically understand there are 3 designs of Intacs. There is 150-degree ring, 130-degree ring, and a 90-degree ring, which can be implanted with symmetric, asymmetric, or single implantation. So cones which are basically have high, which are central and have high spherical error, we go for a 150-degree symmetric implantation. For a cone which is decentered and has predominantly higher cylindrical power, we can go for either asymmetric or a single implantation. And for patients who have low spherical and high cylindrical refractive error or hyperopic error, therein we can go for either a 130-degree ring or a 90-degree ring implantation. Important is to understand the pre-surgical planning for the success in these patients. We need to have certain baseline parameters, which is the patient's manifest refraction, best corrected and uncorrected visual acuity, and a corneal topography, on the basis of which we identify the patient's incision axis, that is on the steep axis, which needs to corroborate both on refraction and topography. Third step is to identify the cone location, whether it is central or decentered, which is done by identifying whether more than 50% of your cone lies within the 3 mm central zone or not. If it lies within it, it's a central cone. If it more than 50% of the cone is decentered from the central 3 mm zone, it's a decentered cone. And hence you need to plan accordingly in these patients for best outcome. Then is to decide the segment thickness, whether the thickness which is decided based on the normograms that is suggested by the company. So basically, these are some examples. The first one where we can see there is a myopia with high astigmatism. So here we go for a 150-degree asymmetric ring implantation. Here again, now we have a low myopia with predominant astigmatism wherein the cone is very decentered, we can go for a single segment implantation. This is a third case where again we have a plano sphere with a minus 1.5 diopter cylinder, wherein an asymmetric ring implantation, wherein a single ring implantation has been done. So now moving on to our topic, which is mild keratoconus with a decentered cone. So here this is a case of a 30-year-old female who had keratoconus. Her uncorrected vision was 660, BCVA was 612. Refraction had predominantly cylinder, which was a minus 4 diopter cyl. Hence, an Intacs with CXL was planned. This is her planning sheet, where we can see that an asymmetric ring implantation was planned, wherein the inferior ring was a 0.4 thickness was implanted. And these are the 4-5-year follow-up of these records of these patients, where we can see from the baseline to the 1-year follow-up, the cone, it was quite decentered. Inferiorly, it became centered. More than 50% of the cone was now in the central 3 millimeter zone. Hence, her vision improved. The uncorrected vision improved to 6.9, and also the BCVA improved to 6.6. The refractive cylinder decreased from minus 4 to minus 1.5, as is the target in all patients of keratoconus. We are not targeting emmetropia, but targeting a decrease in the refractive astigmatism. And again, in the 5-year pictures, you can see that the vision was maintained at 6.9 with the cylinder remaining at 1.5. Now, to confirm our hypothesis and to confirm our results that Intacs does work in keratoconus patient, we did a retrospective study wherein all patients who had undergone an Intacs implantation and had a record available for more than 5 years, the records were reviewed. 24 eyes of 20 patients who underwent Intacs and had more than 5-year follow-up data were recruited. There were 10 males and 10 female. Average age was 25.8. The mean follow-up study was 7.1 years, and it varied from 5 to 11 years follow-up time. Majority of the patients were mild keratoconus, while 13 eyes were stage 1, 6 eyes were stage 2, and all had 2-segment implantation. So what we saw in the study was the visual acuity improved from 0.29 logmar to 0.12 logmar, which was a significant improvement, the p-value being 0.02. More than one line improvement was seen in 55%, and only one eye, that is 5%, lost a BCVA by less than one line. So this was an interesting finding to see that the loss of BCVA is not as common as we see that is reported in literature. Looking at the refractive outcomes, that is the manifest refractive spherical equivalent, it decreased from minus 3.35 at baseline to minus 2 at 10 years follow-up. So here we were looking at patients who had the 10-year follow-up data, and a more than 1 diopter decrease in the manifest refractive spherical equivalent was seen in 55%, while an increase by 1 diopter was seen in only one eye, that is 5%. Looking at the change in spherical power, again, the spherical power also showed a significant decrease. The cylindrical power showed a cylindrical drop from minus 3.8 to minus 2 diopters, and a p-value was 0.01. Looking at the changes in q-value, which tells us about the shape of the cornea, it did improve and showed a decrease, improvement from minus 0.8 to minus 0.47, suggesting an improvement in the sphericity of the cornea. Then again, looking at the Kmax also decreased, suggesting that our CXL did work and the Intacs did regularize the cone and induced some amount of corneal flattening. The K-mean also showed a similar result. The thinnest pachymetry, it was interesting to see that the pachymetry decreased only from 452 to 422. Some amount of decrease is bound to happen because we are cross-linking the eyes. The tissue is bound to become compact, but there was no case of progression of keratoconus in these patients post Intacs plus CXL. Yes, there was some adverse events in these patients. 3 eyes did have a corneal melt for which explantation was required. But in these patients also, there was no loss of BCVA or progression of keratoconus that was noted. There was vascularization of channel noted in 1 eye and lipid deposition noted in 2 eyes. Hence, it is always advisable that a lifelong follow-up is essential in patients who undergo Intacs with CXL. A logistic regression analysis was also done for these patients. However, none of these factors which have been listed here was found to be a significant risk factor for resulting in a corneal melt and risk for Intacs ring extrusion. Review of literature, as we all know, suggests that they show improvement in the cylindrical values, spherical values, and manifest refractive spherical equivalent. Hence, I would like to conclude that Intacs and CXL can be safely done in patients with keratoconus. It improves the visual acuity, refraction, and topography. But yes, lifelong follow-up is essential in these patients. These are my references. Thank you.
Thank you, Dr. Pranita. That was a lovely presentation. So moving on to our expert panel. Dr. Maipal sir, what are your thoughts on this? And Dr. Pranita presented a study where she studied 24 eyes. What about studies where more eyes have been studied, and what is your thought?
So actually, I'm in the between the devil and the deep sea because Pranita has presented my cases and Shreyas happens to be my son-in-law. So, so you tell me, what do I need? Anyway, I think.
I want you to tell the truth and nothing but the truth.
Anyway, so leaving aside that, I personally am a firm believer, as Pranita said, that whenever you are looking at a borderline or a topography or a keratoconus, already there is the possibility of having an ectasia, or there is an ectasia, and thinning the cornea further is obviously something, as a corneal surgeon, it militates in my mind. But obviously there are some studies that are coming out which is showing that the results are pretty good, and there are a lot of centers which are doing that. I personally do not do this particular procedure because I've had those Shreyas talked about the positivity of all those things. I am getting haze once I am doing topo-guided along with the cross-linking in some of these cases, which again, or in a extra procedure that you do in such cases. So that is one thing that you should be aware of in these cases where you're getting topo-guided regularization. I will not deny that there are a lot of reports which are saying that this is a good procedure and that you can take about 20, 30, 40, 50 microns, whatever, not more than that in these particular cases. The idea is to preserve the cornea and to do the other particular thing, that is the regularization. Now, one thing that you have to see is that when young girls in pregnancy, when there are hormonal changes, if there is an Intacs that has been done in them earlier, then it has been shown reasonably well that the progression, because both of them are supplementing each other. That means the cross-linking as also the intracorneal ring segment. So the progression is not seen in these particular cases, while in the cases where only a cross-linking or a topo-guided with a cross-linking is done, chances of having a progression could be there. I don't know, maybe Shreyas can, I have not done a detailed review, but are there any instances of these particular things when these ladies have pregnancy, that is there a progression or not? So I think both the things are pretty good, but I am firmly myself in the camp of doing intracorneal ring segments. And we do whenever we feel that the spectacle best corrected visual acuity is not improving in the keratoconus cases, where we feel that we need to augment cross-linking. Along with that, I don't really do a topo-guided, I do intracorneal ring segments. So that's my personal take, but maybe I have not been into the field to kind of comment on how the results would be if I do some ablation regularization. So I will, I just gave you my personal opinion as to what I do as a corneal surgeon. And yeah.
Thank you, sir. Dr. Chitraman, which were the cases which you would not do topo-guided regularization?
Topo-guided regularization is for mild to moderate cases. So if the corneal thickness is going to be less than 400 micron or maybe 380 micron, because we are going to, there have been cases where we have just done a regularization without any refractive correction in a thinner cornea, but 400 microns is largely the limit. Some decentered cone, if there's inferior superior asymmetry is significant. So in that kind of case, sometimes what would happen is the topography would get regularized, but you would have induced a small myopia because there would be some flattening which comes onto the central area. Imagine the inferior thing you're treating, some amount of ablation comes into the central visual axis area, and that acts like a myopic ablation, and so that is the challenge. So you need to tell some of these significantly decentered cones that you're regularizing their topography. Definitely their quality of vision is going to improve a lot, but they might find that they need a spectacle correction. So in those specific cases, it forms a very small minority. As Shreyash had shown, we have innumerable cases, centered and decentered cones have done very well. Haze has not been seen at all by me. I wouldn't want to know, maybe one odd case went to Shreyash. I have been in the last 10 years. It's because probably besides the accelerated cross-linking, which is used in all these, and the amount and the use of mitomycin, which we are using, and the topical steroid drops, which we taper it over 3 months period. All of this adds up to see that there's absolutely no haze. Even by the 5th day, these patients look so happy. It's
So
palpable happiness. Palpable happiness.
So you're using FML?
Yeah, loteprednol.
Loteprednol. Okay. Thank you, ma'am. Dr. Titial, sir, so would you please summarize and in 2 lines or 2 to 3 lines a take-home message to our viewers regarding topo-guided regularization versus Intacs? Just a brief summary before we move on to the next.
You have to unmute yourself.
Yes.
Can you hear me?
Yes.
Sorry, I think both the procedure have a space in a management of keratoconus cases. As far as Intacs are concerned, these are cases like mild to moderate cases where Intacs does very well in management of keratoconus, and combining that with the accelerated cross-linking has given quite a good results in our experience also. As far as topo-guided smoothing and correcting the irregularity sometimes does work in combination, but classically alone doing that treatment sometimes doesn't suffice. So I would be rather keen of doing Intacs in most cases where corneal thickness gives around 400 or so, and results are quite good. But those patients where I have to do a topo regularization would be after the patient either going for a cross-linking or after the cross-linked corneas, or some patient who have undergone Intacs also, there we can do it. But alone, I have not done many cases. I have no experience doing it, just a topo-guided in case of keratoconus. But cases are there, but I think there's a limited cases where these procedures may be required.
Yes, significant mild cases. We have about nearly a decade's experience, and honestly, it has to be adapted. It should not be a debatable argument at all anymore.
Yeah, that's true.
Thank you. Thank you so much, everyone. So we move
madam,
on.
if you don't mind, just one line, madam. Just to unbiased point, not pertaining to the debate at all, but just as a take-home point, we were doing a very large number of intracorneal ring segments over 10 years ago or 12 years ago. But now, after using this, not just Eye Foundation, but I think Narayan Netralia, LV Prasad, so many places where the usage of this was confidence gaining in this procedure, now almost the entire spectrum, starting from a Kmax of 46, 47 early keratoconus to about 58 Kmax, we are managing very, very nicely with topo-guided treatments. And it's only a very small segment, because beyond 65, only contact lenses work, or beyond the extreme, you go to bulk. But it's a very, very small segment of Kmax with suboptimal vision, with lesser pachymetry, where you can do Intacs as the only option. Majority now has shifted to TGPRK or contact lenses. And genuinely, I mean, I'm not saying this for the sake of the debate because I spoke for TGPRK, but genuinely it has come down, and our numbers over the last decade, it's going on dipping. And I think it will continue to dip in the years to come because of our ease. And now with Shwind Amaris coming out with topo-guided PTK platforms, which many of us are using, we can actually decenter the PTK, use a much less ablation, get a greater amount of flattening and excellent repeatable results. So, I mean, I think now the debate of whether ablating tissue can cause progression is long gone. Canalopolis has even published 12-year outcomes, which are all extremely stable with the Athens protocol.
So Shreyas, is it machine specific specifically, or all machines can do it?
The decentration and the customization of the PTK currently is available only with Shwinda Maris, as per my knowledge. I'm not sure if it's there in any other platform. Whereas, of course, the Wavelight and
that also becomes a problem, I suppose, because it's not available across the board. Because
no, maybe the trek part is done by Shweta, but the other parts are very well.
Topographic guided treatment now is available in many platforms.
Yeah, that's
Only
fine.
the
But, with less amount of tissue that you are talking about, so that's
yes.
Even
Dr.
Gaurav
Shreyas,
would have his experience.
Dr. Shreyas, you can compare your Intacs results and Topo-guided PRK results.
We have
10 years down later, whether how many will require DALC. You can compare.
It's painfully poor, the Intacs results. Let me tell you that we've had enough extrusions, enough vascularizations over time to tell you that Intacs results are painfully poor in the long term. Yes, there are some patients who do benefit and continue to remain so, but they are the lucky few. And whereas with TGPRK and generally with mitomycin C usage, we rarely see haze. And these are all, again, mild to moderate keratoconus. We are not using them in advanced cones at all.
I really don't agree with a very high percentage of extrusions. I don't think in our hands we have had a very high. I don't know.
We've hardly.
I'm not saying it's a high percentage, sir, but the idea is that it does happen in a significant enough number to say that in the long term that there are complications and there are things, and especially if the patient has allergy, VKC, vascularization into the channel does happen quite often.
I understand, but even if you have to extrude the intracorneal ring segment, it does not lead to any kind of visual loss, nor does it lead to any progression in the cone.
If you take up TGPRK into your system, you will have your refractive practice going to an entirely different level. Don't lose.
So I'll ask you to give me a.
Yes. 20 minutes.
I'm sorry. Okay. Go ahead, Anaga. I had a question for Shreyas, but we'll go on. Hi. I'm sorry I was late. I just had a quick one for Shreyas because, I do a lot of topo-guided PRK as well, and I'm really happy with it. But we've had 1 or 2 patients where we got significant haze and scarring, just out of the blue, in spite of mitomycin and everything. So I was just wondering, what's your percentage of patients who might get significant haze?
So the haze of a PRK and the haze of a CXL has to be differentiated. The haze of a PRK is usually subepithelial, reticulate, superficial, and is more or less diffuse or arcuate based on how you have ablated. But the haze of CXL is usually a deeper, a denser, and in a more striate crisscross pattern. So that haze, unfortunately, we can't control all the time. I mean, the haze with CXL occasionally does happen. Yes, it is less common with the HPMC solution. It is less common with the accelerated protocols. But with Dextran and the standard protocols, haze does happen every once in a while. Again, protection from excess UV exposure, glasses, sunglasses during the healing period, waiting for full epithelialization, stable epithelialization to happen before we remove the BCL are all factors which will help in reducing the extent of haze. But with TGPRK, the haze induced by the PRK itself can be negated by using mitomycin C, although it does not negate the haze induced by cross-link or the scarring induced by cross-link.
Yes,
Sorry,
let's
madam.
move on now. No, thank you so much. It was a great discussion. So Dr. Rushad and Dr. Mukesh are both here, right? So we'll go on to their debate. So the scenario is a -9 diopter patient with a pachymetry of 550, anterior chamber depth of 3.5 millimeters, Lasik versus Phakic IOL. Dr. Rushad versus Dr. Mukesh. Dr. Rushad, you can start sharing in the meantime. Okay. So Dr. Rushad Shroff is the medical director of the Shroff Eye Center, Delhi. He has 20+ publications in international journals and is presented and won free paper and video awards at various international and national conferences. Yeah, over to you, Dr. Rushad.
Is my screen visible?
Yes, you would be speaking for Lasik. Yes. Screen is visible. You're audible.
So thank you, ma'am. Thank you for the invitation to be a part of this webinar. So I'm going to be talking on Lasik in this particular scenario. And at the outset, it seems like a losing battle, but I think I'm going to try and fight it anyway. So let's look at high myopia and ICL. What is the argument that I'm sure Dr. Mukesh is going to make is that corneal procedures like laser ablative procedures are not reversible. Generally, they're recommended for lower powers, not for high myopia. Refractive lens exchange, etc., and lens-based procedures like phakic IOLs generally do well in high myopic patients with excellent visual and refractive outcomes, and it is, of course, reversible in the case of phakic IOLs. But there is a lot of literature that talks about certain issues with phakic IOLs, and let's go through them one by one. The common intraoperative problems that you can have are walled sizing, abnormal positioning of the ICL, a loss of corneal endothelial cells, secondary glaucoma. You can have cataract developing and night vision symptoms. So in this, there is importance of looking at the specular microscopy in a much more detailed way. In fact, there have been publications that have talked about loss of endothelial cells post ICL, especially if the vaulting is not absolutely correct. And this can lead to long-term corneal issues in the patient. We also see a subset of patients who have anterior segment inflammation in phakic IOLs. And this happens regardless sometimes of how well the procedure has been done. Even a slight amount of manipulation leads to pigment dispersion, which can lead to inflammation and long-standing issues like recurrent iritis. You can have pigment dispersion syndrome. You can have synechia forming as well. Also, in rare cases, because it's an intraocular procedure, you are exposing the patient to the risk of endophthalmitis as well. The other thing that one has to be careful of in phakic IOLs is the occurrence of iris cysts or ciliary body tumors or various different configurations where actually the requirement of a UBM may be more important to highlight these particular issues. Otherwise, you can have a sizing a surprise after putting the ICL, which you may not be able to notice prior to doing the surgery. Again, in narrow angles in phakic IOLs, it has been shown that there's acute angle closure glaucoma that has been reported secondary to ICLs, which can lead to an ophthalmic emergency. And a patient who's going in for a refractive surgery ends up with acute attack of glaucoma, which of course is a medical emergency and can lead to really poor outcomes post the procedure. Coming to cataract, although with the central flow system in the ICL and the various different indigenous manufacturers and their particular designs, the incidence of cataract has come down. However, there is still a risk of cataract formation. Again, this exposes the patient not only to a second surgery, but again, because you're going in twice intraocularly, there's endothelial cell damage. And again, you're exposing the patient unnecessarily to a second procedure. Apart from that, Lasik generally is not associated with as high a rate of retinal detachment post surgery as phakic IOLs, as I can show here with these various different publications. There are even reports of CNVM and submacular hemorrhage being developed after ICL. So are we limiting our choices for high myopia correction by just going in for ICL? Can Lasik be a superior option in selected cases? Now, this was a paper comparing the optical and visual quality in ICL and femtosecond Lasik, and this showed that both of them showed pretty good outcomes in terms of optical and visual quality, as well as safety in terms of refractive outcomes. The strengths of Lasik in a high myope: one, patients always talk about Lasik, they're more comfortable accepting the procedure. It's safer in patients where you have a borderline endothelial count. I wouldn't do it in someone with a full-blown Fuchs, but if someone's counts are not exactly fitting the criteria for an ICL, a Lasik is a good option. The chances of glaucoma and cataract are lower in comparison to ICL. It's a viable option in patients with a low anterior chamber depth or narrow angles, and definitely it's cost-effective for the patient. So coming to our scenario where we have a -9 diopter sphere with a pachymetry of 550 and an AC depth of 3.5 millimeters internally, Assuming a normal topography, let's look at the calculation. The flap thickness would be about 110 microns. The ablation depth for 6 mm optical zone would be about 117 with a good residual stromal bed of about 320 microns left over. If you look at the PTA calculation, it's about 40-41%, which is at the cutoff. Let's look at the ectasia risk scoring for this particular scenario. And you would see that generally because of the RSB being good, the age has not been mentioned, but let's assume it's about 25, a good corneal thickness and the mean refractive spherical equivalent being between 8 and 10, it still falls at the low risk for ectasia in this particular scenario. So to summarize, in every refractive procedure, it's a thorough history taking is important. The age, the mean refractive spherical equivalent, the corneal topography would be important before taking this decision. Residual stromal bed, the PTA, the ectasia risk assessment score, and then of course, if everything is met in these, like it is in this particular scenario, a Lasik would be a decent option. Thank you.
Thank you. Thank you, Dr. Rusha. That was an excellent presentation. So speaking against you is Dr. Mukesh Paryani. He is the, you can start sharing, Dr. Mukesh. He's currently working as the Department Head Refractive Surgery, HV Desai Eye Institute, Director of Neovision Eye Care in Pune, awarded prestigious YKC Pandit Awards and the Young Achiever Awards at the ISCARIS meet. So over to you, Dr. Mukesh.
Yeah, thank you so much for having me here. And is my slide visible?
Yes, yes.
Yeah, thank you, Dr. Rushad, for making it very easy for me. For this particular case scenario, I actually found a topography matching the scenario. So I put the topography here with the patient's Phakic exactly 550, 9 diopter myopia, and he has a good chamber depth, 3.5 as it is said. Even if it's from an epi or the endo, doesn't matter, because still we'll be able to do a good phakic IOL surgery in this particular patient. Now, as you said, I'm also going to start, why will I not do a LASIK surgery in this particular patient? For your happiness factor, the same calculation I also did. And we found that, okay, as per the Randleman criteria, you are pretty safe. You have a residual stromal bed of 333. But we also know that high ablation depth itself is an independent risk factor for development of ectasia, and it's been proven for more than a decade right now. Not only that, the PTA paper clearly shows your PTA calculation showed 41%, mine was around 39.8, and it's still high. And PTA higher or equal to 40% had the highest odds ratio and highest predictive capabilities for ectasia, and is certainly a borderline case for doing a corneal-based refractive procedure in this particular case. Well, even if you say it's pretty safe, we have done so many cases, what about the visual quality? We know the higher order aberrations will increase as the dioptric power, the more correction we do, the more visual quality deterioration is seen. Also in the form of reduced contrast sensitivity, glare, halos, difficult driving. This is despite we are considering that the patient's pupil will be small. Anywhere we can land up patients with a pupil 5.5 or more, you're going to have patients having trouble in the dim light conditions for sure. Beyond doubt, it's been proven beyond that the ICL implantation induces very fewer HOAs as compared to a Wavefront guided Lasik, and the contrast is on the other hand improved in particularly the moderate myopia or the high myopia. And there are many studies. I have, just for the sake of it, I have put only 2 studies. Not only that, you are going to ablate the cornea for 9 diopters. We know, although it is a 550 Phakic good topography, otherwise normal patient, but we know that higher refractive correction has got a reduction in the overall stiffness and can cause biomechanical issues and higher chances of ectasia in this particular patient. Now, further things to ponder in this is the amount of dryness that you're going to cause the patient, possible regression, higher refractive error, higher chances of regression. We're going to look into those patients, possible undercorrection, the flap architecture related complications, and obviously, as I said, the pupil factors cannot be ignored. Phakic IOLs, on the other hand, in this particular case, I would ascertain that the retina has been assessed, whether it's a refractive surgery which is cornea based or a Phakic IOL based. The retina has to be assessed. No chances of ectasia. It gives a better visual quality, no induced aberration. Actually, the aberration profile of the patient increases, no dry eyes, no difficult driving, no glare, no halos. And above that, there is no investment from the surgeon side. There is no overheads of the laser related stuff. And it is certainly a reversible procedure. New gen phakic IOLs and the better pre-op diagnostics have made sure that we have lesser wall-related issues. How many patients actually nowadays we see with a very high vault or a very flat vault, and even if it's there, it's easily reversible and exchange can be done in a very easy way. We have lesser IOL spikes because most of them come with a central hole. PI pigment dispersion incidences have come down because the materials of the phakic IOLs have improved. Lesser cataract formation is seen nowadays, with particularly the central hole coming into play, which improves the oxygenation in the central part of the crystalline lens. And if you compare both, certainly it is proven beyond doubt that they perform really better as compared to a cornea-based refractive error. When we are talking about a very high myopia, the phakic IOLs really do well in this. So the conclusion, I would like to do a conclusion with a question. What if it was you? What if it was you as having a cornea of this and average pupillary size 4.55 mm? Would you still like to go ahead with a Lasik surgery, or perhaps do a good assessment of your eye, assess the safety of the phakic IOL and go ahead with a phakic IOL? Thank you so much.
Yeah, thank you, Dr. Mukesh. That was an excellent presentation. So coming to our expert panelists, is Dr. Amrish Sarat sir here? Dr. Amrish sir? Okay. Dr. Gaurav, a question to you. Now, if the anterior chamber depth from the endothelium instead of say 3.5 was 2.78, what would be your procedure of choice? And secondly, instead of Lasik, would you prefer a femto Lasik, a smile, or a silk procedure? Silk, definitely Dr. Mahipal sir also would give his comments.
So actually, 2.8 is my cutoff. And, I also look at some other factors. I look at, the dysfunctional lens index of these patients, because some of them with very high myopia may have poor DLI. And, that helps decide. Of course, here in this case, because we are doing either a corneal based or a ICL based procedure, it won't make any sense, but DLI will not really influence our outcomes. However, I would actually be equally good with a smile or with an ICL for this particular patient, especially with the good AC depth. But with 2.8, I would also look at the lens rise and everything, and that would help me decide whether, I'm okay to proceed with the ICL.
So with a 2.78, you would specifically not do a phakic IOL, right?
Not necessarily. 2.78 and 2.8 is
So
in
what
my
is
eyes
your
exactly
actual cutoff? Like
my
with a
cutoff is
2.78.
2.8,
Yeah.
but then I would start not looking at ICL when I was going down below 2.75, because the error, if you compare three devices, you'll probably get a 2.8, 2.85 and 2.75 on three different devices. So I like, for example, nowadays we are measuring on Anterion. Anterion is OCT based. We are finding that, on Pentacam, some patients have like a 2.73 or a 2.74, and on the Anterion, we have a 2.81. So those things.
Actually, even with the same machine, you may get three different readings. So
right. So I think we have to then, if you have a borderline patient, first thing is measure your AC depth on 2-3 different devices so that you're sure what you're dealing with. And I don't like to compromise with shallower AC depths than 2.8. If I'm effectively getting on all devices below 2.8, I will not proceed with an ICL for sure. I may offer the patient with a slight undercorrection. Sometimes patients are happy to get, they're actually wearing sometimes a -8 and you're getting a refraction of 9, and they'll happily have half or one diopter of undercorrection. Some patients, and you have to kind of deal with each patient differently, I think.
Dr. Titial sir, which machine would
for
give
sure
you
smile.
the most
Sorry, another. For sure smile, not Lasik.
Yeah.
Okay. I'm sure Dr. Mahipal sir would say silk.
Why should I say just silk?
Just joking. Dr. Titial sir, for the benefit of our viewers, which would be the machine which would give you the most accurate anterior chamber depth, and would you rely on?
Nowadays, we do an IOL Master 700 for all these cases, OCT-based measurement, and that gives the best assessment.
So would you take multiple readings or would you take only one reading?
The multiple readings are taken when you have a doubtful AC depths. If you have a better 3.5, then the one single assessment is good enough. If you, as Dr. Gaurav was telling, if you are around 2.8, 2.76, then yes, you might do a multiple reading for other instrumentation. And there also I would add towards the, towards the cellular one, because that will give us a better idea.
Okay. Dr. Maipal, sir, your take on what procedure would you do in this?
Yeah, so I think before I go on to that, Gaurav, this is a observation I have also got on the interior, and it's always a little bit like I was trying to reject patients based on the pentacam, but the interior gives you a slightly this thing. So what to rely on? That's one of the questions as to which of the two is better, because I think when earlier the 2.8 was fixed, that the interior never existed at that particular time. So should we, because yes, it always gives a little higher reading. I don't know why on OCT based it is giving a higher reading, but I have seen it in 3-4 cases where I had a borderline this thing and I did an interior, and interior showed me 2.83 or 2.84 and from a 2.78, and then I went ahead and did it. So I personally am a little confused that if we are getting a higher reading on another machine, should we err on the side of caution of taking the lower, or err on the side of aggression as taking one of the machines to be higher? So I really don't know if anybody has an answer on that.
The OCT-based machine would definitely be more accurate. But then if there are two difference in two modalities, we would rather err to be more cautious.
That's what I'm saying. See, the point is when 2.8 was kind of come to a conclusion that 2.8, at that time, the Interions or the OCT-based machines were not in existence. So the 2.8 was done basis the pentacam. Even the IOL Master 700 was not there at that time when the 2.8 limit kind of was set. So basically, yes, it may be more accurate, but the inaccurate was taken as the baseline. So should we continue with that or go towards more accurate and become more lenient in our this thing? That's just a question. Sorry.
In high myopes and higher refractive errors, the peripheral AC depth also comes into play. It's not just the central AC depth. So I think there's no harm in being extremely cautious in these cases. 2.8 coming to 2.78 may be acceptable, but not 2.7 we should not take on at all.
Okay, and to then answer the question that was asked as regards what I will prefer, see, basically you can't give a clear-cut answer like you, instead of 3.5, you came on to 2.8. So it will depend on what the total anatomy of the eye, the corneal physiology, corneal topography and the corneal thickness, etc. is. Everyone has their own cutoff limits, and my cutoff limit is a total of about 10 diopters. So this falls at -9. Some people have in Germany, legally you cannot do more than -8. Okay, that's legally you are banned from doing -8. So basically it depends where you want to keep it. I normally keep it at a -10. And definitely, as Gaurav said, I don't think there'll be any difference between a silk and a smile, because that's the ease of lenticular dissection that we are talking about in the silk. The quantum of tissue that is taken out is the same. So that I don't think that's a discussion we need to go into. But normally a 6 millimeter lenticule on post lenticule removal, if you do a topography, you get a 6. But if you had put a Lasik, if you do a 6 optical zone and you do a topography later, it will be 5.3 or 5.4. So that is one thing, that the night problems or the problems as regards the quality of vision deterioration would be much more in a Lasik as compared to that in a smile. And I normally prefer to, in such cases, do a cross-linking along with, so I do what is known as a smile extra. So this is a case where depending, see, there are a lot of patients who haven't heard of ICL and they kind of don't want an intraocular procedure that is there. So I will offer both to them. I'll be comfortable with both, but in this particular scenario, I can do a cross-linking along with a smile also. It's not a no-no for me at all that I cannot do a smile with a cross-linking.
Okay, so Dr. Chitra ma'am, one question. Now,
About
if
-8, I would do phakic IOL. We have moved off totally above -8, unless the depth issue is a challenge.
Yes, ma'am. If the patient is say -9, but the corneal tissue is a challenge, and you have to keep the patient myopic, say -1 diopter as a 35-year-old patient, would you prefer to keep a target -1 and go ahead and do Lasik if the patient is not affording phakic IOL?
No, our Smile is going to be as costly as these Indian IPCLs. So I don't think
So
that.
have you ever done a patient, even if cost is not a factor,
Yeah.
would you go ahead and do a patient for Lasik, whichever procedure it may be, Lasik or Smile, and keep the patient -1 diopter, and the patient accepts it because for her -9 to -1, she accepts it. Would you go ahead and do it?
I mean, I would have done it in my earlier days when phakic IOL was not being done in plenty. But if the phakic IOL is out, I would go ahead and do the full -9 if the corneal thickness allows. And as Mahipal said, we have done Smile extra before, but now our extra procedures have totally moved on to only PRK extras. Because I do believe that Smile, like in flap, there is a biomechanical weakening. So I do not think there's a very big role of Smile extra. Probably the context would be some regression, like regression is, I don't know. These are all, just anecdotal. We don't have any proof, but PRK extra, it makes sense. I know I'm veering out of it because of the Smile extra statement.
But one particular thing, Dr. Chitra, I'll ask you a question because you are the, not to say maybe you have the maximum experience. I was going to say something else in laser vision correction. So we have done on the Summit system -16s and -18s, and I'm still following up those patients when there were no phakic IOLs were there. The first one I did was 1999 or something like that. But there are these patients who at that time we did not understand that much of ectasia, and we routinely crossed -12, -14, whatever it is. And it is not just the thickness of the ablation which matters. There is something else. And I have not, touch wood, had any patient of ectasia with such high powers. Rather, a -2 or a -3 has come back with an ectasia or something like that. So those are certain facts which are there. It's the quality of vision that we are talking about. If the quality of vision is all right, and the other parameters, the topography is fantastic, and the PTA, etc. there, and the TBI today, we are looking at that. If all those things are there, I personally feel that my limit is 10, and that's more because of the quality of vision. And you can actually, I am not very keen on the Indian made. Maybe I'm a bad surgeon, but I have not had great results with the Indian phakic implants. Our go-to lenses, because you're just saving about 20,000 rupees or something like that in the cost. It's not a phenomenal difference between the Indian and this thing. The stability and the outcomes of the ICL in my particular hands are much better than what I have in the other ones.
So I just don't want us to argue on this, but all of them are doing extremely well. We cannot be biased on that. I want you to start adopting that. I want you to do Topo-guided PRK and beat us all at this game.
Dr. Anaga, can I ask a quick question because it's very relevant here? There was a recent publication in IGO by Dr. Jeevan Ladi on small optical zone smiles, and he was doing like 5 mm and all, high myopia, and I think even less than. I mean, I was like initially shocked to read that, but then he kind of has done a lot of work on it and he published it. And I'm just asking, because they are stalwarts of smile sitting here, Dr. Titial, Dr. Mahipal, Dr. Chitra, and everyone, that what are your thoughts on that small optical zone for high myopia that Dr. Ladi published?
I don't think that
we used to routinely do 5 point. If you went on the tissue saving mode, whenever you go on the tissue saving mode, if you remember, even the Bosch and Lomb machine had a tissue saving mode, the Summit had a tissue saving. So if you reduce the optic zone, that is when we would go higher, because the depth of ablation was the only thing that we were looking at. I don't remember having any significant number, or even I don't remember that I have had so many ectasias or a plethora of ectasias where I have done a 5 mm ablation. So I think it's the same transfer.
No. I'm not worried about ectasia. I'm worried about quality of vision.
That is what I'm saying. A 5 millimeter smile
at all. 5
millimeter smile.
I mean, Mahipal has done, I have done, but I wouldn't do it now. And with such wonderful results with phakic IOLs, with high parts, and a mediocre surgeon can get away with it. I think we need to conclude this saying that in the first segment, Topo-guided PRK, yes, has to be incorporated. And a phakic IOL is the answer for high myopes. and there is no second thoughts on that. There should not be a second thought.
With that, we move
Definitely
on
the
to the
quality
next.
of vision deteriorates. We have done it
Thank you,
all,
ma'am,
but
for
we have
summarizing.
grown beyond it.
Thank you, ma'am, for summarizing. So let's move on to the third debate. Dr. Amjad, furniture wala, and versus Dr. Rashmi Deshmukh. So the scenario here is a minus 5.5 diopter patient with a pachymetry of 485 with borderline topography and anterior chamber depth of 3.5 millimeters. Dr. Amjad, please start your presentation. He is the founder and medical director of the Orbit Eye Hospital, tertiary eye care center in the heart of city Mumbai, with all subspecialty departments, which has NABH accreditation and is a prolific cataract and refractive surgeon. Yeah, over to you, Dr. Amjad. You would be speaking to us on advanced surface ablation. Yeah, your slides are visible.
Is it visible, Anaga?
Yes, yes, and you're audible. So please go ahead.
Good.
Yes.
Good evening, everyone. At the outset, I would like to thank the AIOS committee and the ARC committee, and with special mention to Dr. Anaga Herul for having given me this opportunity to share my insights on surface ablation. And it is a great sight to have my mentor, Dr. Gaurav, on the panel. Thank you, Gaurav, for all the insights you've given me on surface ablation. So with my limited time, I would like to stick to the case scenario. So in the given case scenario, if the pentacam is normal, the clear cornea, no cylinder, a moderate spherical error of 5.5 diopters with a borderline topography, and a thin cornea, without a doubt at the back of my mind, I would consider surface ablation. Now, let's run through the calculations. I have been using Schwinn-Damaris for the last 14 years. But in 2017, with the new advent of this new profile of smart pulse technology, my practice of surface ablation has taken a complete turn. Now, if we run through these calculations, what we see is, even if we plan a good optical zone of 6.7 millimeter with a healthy transition zone, so to a total ablation zone of maybe something like 8.25 millimeters, as we can see on the slide, we still end up with a very thick, healthy residual stromal thickness of more than 340 odd microns. Hence, the efficacy and safety both won't be compromised in such a case scenario. Now, whenever we've spoken about surface ablation to my colleagues, there has been a lot of talk about the pain, the time in the visual recovery, sometimes the haze. But this has all been really taken care of with the use of mitomycin C now, and also the change in the ablation profiles. This is the ablation profile we've been talking about. So previously, all the ablation profile were based on the XYZ coordinates. Now with the smart pulse technology, this is based on a Fullerene's principle. Now, what does this mean is every spot is equidistant from each other. This is something like this. It's on a 3D surface where, on the basis of a Fullerene principle, every spot is more equidistant from each other. Now, what does this gain? How do we gain from this? We end up getting a very good, smooth residual stromal surface. And how does this translate into our benefit is, the patients have, in most cases, a 6/9 or a 6/12 partial vision on day 1 of the procedure, post 24 hours. There is the pain component is significantly less. Haze, any which way, we are seeing much lesser than what we used to see a decade ago with the use of mitomycin C, obviously. So putting all this into aspect, and here, I just put in these 2 slides quickly. See, one is this image, which has been definitely borrowed about topography rings immediately after smart pulse technology used ablation. And you can see this more justifies about the smooth stromal surface we were talking about. These are, again, the electron microscopic images done in cases with and without the smart pulse ablation profile. So all this sums it up that if we end up getting a good, smooth residual surface with a surface ablation, such procedures are more advantage for the patient. It's like a flapless procedure with very less risk involved. I usually stop the antibiotics on day 4 after complete epithelial healing. The patient can take a head bath, can proceed with most of the sports activities, and can, even for female colleagues in Mumbai, where they're more demanding with their cosmetics, they can start with their activities. And from the scientific front, it preserves the corneal biomechanics better. I feel it's a more healthy procedure. Vis-a-vis in such a case, though I do a lot of phakic IOLs, both Indian and the Star Visan ICLs, but I prefer in this case, a surface ablation would give me better results. Thank you all for your time and attention.
Thank you, Dr. Amjad. That was a lovely presentation. Welcome, Dr. Rashmi Deshmukh. She has done 3 cornea fellowships. First, refractive fellowship at NN, a clinical research fellowship in cornea and ocular surface at Nottingham with Professor Dua, and then a 3rd cornea fellowship at Cambridge University, and she's currently a consultant at LVPI Hyderabad. So over to you, Dr. Rashmi.
Thank you, ma'am. Thank you for having me. So I am going to try and talk to you guys and convince you about phakic IOL in this scenario. So current scenario is a refractive error of 5.5 diopter minus 5.5 diopter. So moderate myopia, adequate AC depth, and a pachymetry of 485 microns. And the 2 options given are PRK and phakic IOL. And I'm just going to, in the next 4 minutes, just bombard you with a little bit of evidence on phakic IOL and how patients fare in long term. So in phakic IOL, usually it is done for patients who are not suitable for LVC, provided their age is more than 21 years and the anterior chamber depth is more than 2.8 millimeters, like we were just discussing, and with a good endothelial cell count. So over the past few years, the phakic IOL itself has undergone several modifications to adjust the optical zone as well as the wall size to reduce the amount of cataract formation and glaucoma that was a concern earlier with these models. So these days, both the ICL as well as the IPCL come with a central hole of around 0.36 and 0.38 millimeters respectively, which helps in better aqueous flow around the lens and reducing the chances of pupillary block as well as cataract formation in these cases. And it has been shown over in a comparative study that the presence of this central hole does not really significantly affect the visual or the refractive outcomes in any way. So whenever we think about phakic IOL, the main concerns that we think about are the quality of vision, early cataract formation, glaucoma, endothelial cell loss, and retinal detachment. So when it comes to visual outcomes, this was a particular study where they compared moderate as well as high myopia. The excimer laser refractive surgery was compared with phakic intraocular lenses, and the study revealed that there was less loss of best spectacle corrected visual acuity in cases of phakic IOL. There was also better contrast sensitivity as compared to patients who underwent PRK. And patient satisfaction by means of questionnaire was also found to be more with patients who underwent a phakic IOL in these cases. And towards the end, the authors concluded that phakic IOL could be considered in patients with thin corneas, but having moderate myopia instead of just thinking of it in cases of high myopia. Then the next concern that we think about is early cataract formation. So here I'm going to cite this study where they studied the changes in the anterior lens density after an ICL implantation for up to 4 years, and they did not find any significant difference in the anterior lens density. And also there was no significant cataract formation at 4-year follow-up. But of course, that is the maximum follow-up that we have. And then coming to glaucoma. So when it comes to glaucoma, we are mainly concerned about pupillary block glaucoma. But these days, like I mentioned, there are some central holes to take care of that. And we also are thinking of crowding of angles, for which we require correct sizing, and preoperative gonioscopy is a must in these cases. But if you have chosen the cases properly, then usually these pupillary block glaucomas and narrow angles are avoided. Then this is another study that also showed that even the pigment dispersion, which happens post ICL surgeries these days, is not significantly different from what would happen in a patient who underwent a laser iridotomy. So again, pigment dispersion and pigmentary glaucoma would not be a concern. Then coming to endothelial cell loss. So this was a study where Phakic IOL was compared with laser vision correction, which included Lasik and PRK both. And they showed that the mean endothelial cell density loss over 3 years was not significantly different between the two groups anyway. So again, that answers our question on how the endothelial cell loss these days is with the current ICLs or IPCLs. And lastly, we always keep thinking about a retinal detachment. This is also something that worries us when we are thinking about phakic IOL. So this was a long-term study which showed that when ICL implantation surgery patients were compared with patients who did not have any surgery, the rate of rhegmatogenous detachment was same in operated eyes as compared to the non-operated eyes. So again, this should, I think, put our worries to rest. Now talking against phakic photorefractive keratectomy. So when it comes to visual quality, like in the earlier debate also, we saw that in the long-term outcomes, there is increased higher order aberrations and reduced visual quality in patients who undergo a PRK. Corneal ectasia, even though rare with PRK, has been reported, and we cannot absolutely say that in a thin cornea that risk is not there. Corneal haze again becomes a problem, especially when you have patients who are not able to manage long-term steroids and in patients who are steroid responders as well. And apart from corneal haze, other complications because of epithelial debridement like bilateral corneal infiltrates and corneal melting has also been reported. So just to summarize, the modern day ICLs are fairly safe and they provide a better visual quality as compared to PRK. And one of the advantages is that the cornea remains untouched and clear, especially in a thin cornea. And if you have a good patient selection, the long-term outcomes would be good. Thank you.
Great presentation, Dr. Rashmi. Yeah, thank you so much.
Thank you, ma'am.
Yeah. Dr. Titial, sir, what is your threshold and what is your cutoff for pachymetry where you would not do a LASIK one and second where you would not even do PRK?
I see Dr. Mahipal is not there. The debate is between Mahipal and Chitra today,
He is there.
Almost for both the cases are similar. And
Titial, I'm very much there. Don't worry. I just switched to my phone because I was planning to go home on the way. Anyway, go ahead.
The 4 presenters have done justification to the point. I think it shows that it depends on the experience of a person who's working on what particular area. If I look into both the cases, like Dr. Amjad talked about experience of Swan Emirates in especially this smart ablation profile, the PRK results seems to be better. But as far as people are concerned, most people may not have access to this particular system. And PRK, as such, as rightly pointed out by Rashmi, has a limitation there also. Like you can have sometimes quite unpredictable in some cases. And you can have haze, you can have regression. As far as I'm concerned, I'm more of a, intraocular surgeon. I would prefer, in all borderline cases, rather doing a corneal procedure, I'll do a phakic IOL. Rightly pointed out beautifully by Rashmi. It is the newer generation phakic IOLs which has given a absolutely beautiful results, not only for a higher degree of refractive, for a low to moderate myopia also.
So how low would you go, sir? What is the lowest refractive?
Lowest I have gone up to 3.5 diopters.
Yes.
So have you done it for a 2.25, 2.5?
Not yet. 2.5
I have
not
done
yet.
it for a patient where it
with
was
the Indian makes now, we are getting a cylinder and even up to 2.5 diopter, we have the lenses. But these cases, you can very well do other procedure also. But I truly agree with the initial debate. Phakic IOLs is a better choice today. And not for a person can go and have a boxing or a swimming within 4 days. That may not be criteria for our patient, but it is the quality of vision which is more important.
If Dr. Chitra ma'am, one answer, what is the cutoff for pachymetry for LASIK and cutoff for PRK?
No, the PRK below 490, I would do PRK, but I want to be telling you that you can get away with doing PRK extra for this patient and do very well. And you could do a phakic IOL and do very well. The patient cannot afford it, an IPCL or an ICL, you could do a PRK extra here. keeping mitomycin.
One minute. Just may I interrupt? So 490 is your cutoff for LASIK. Does everybody agree, or 480 is the cutoff?
480 is the cutoff if the corneal topography, other things are normal.
Assuming it is normal.
Yeah.
Assuming topography and tomography is normal, is 480 the cutoff or 490 for LASIK?
490.
Mine is 490. So Chitra and myself are agreeing here. So
For a change. Dr.
so
Rohra?
mine is 490. Yeah, and PRK is 450.
480 Lasik or PRK?
No. 490 is LASIK. For PRK, either 460 or 450. So maybe 460 is what I use. So 460 and 490 and -6 for PRK as I don't go more than that.
But does everybody agree, or it is the same? Let us just finish this. Dr. Titial sir, do you agree 490, 460 and -6? Anything
I have
different?
a cutoff, 480 is a Lasik cutoff and PRK 470 is a cutoff.
Yeah.
480
Only
and 470.
Only 10 micron difference.
They have almost similar.
No, but sir, 10 micron, lot of patients in those 10 microns also.
But depends on what's the corneal thickness profile as with the topography profile also.
No, that is understood. But the point is that at least you are at least saving 50 microns. See, even if you are doing 100 micron femto flap versus the surface ablation, you are saving 40 microns of thickness, right? So would you not reduce it by 40? Only 10 microns you are reducing.
Yeah. 460 if I would do a -1.5 diopters, and that too I'll do a PRK extra. But 470 for a -5.5 with 485, a PRK extra.
So Chitra, may I ask you what is your PRK extra protocol, please? Because you are talking a lot about PRK extra. But I frankly feel that there is no role for PRK extra except in topo-guided PRK for borderline or keratoconic corneas. Otherwise, I don't see it's an overkill.
Yeah.
No. We have been. It's just that we'll have to show all our results. PRK extra, we would not misuse it at all. We have stopped Smile Extra. We've done so much of Smile Extra.
Madam,
but 485 with -5.5 is a little steep. So if in that situation, I would do PRK extra if my patient cannot afford a phakic IOL. But if it was -3 and a 485, I would not do a PRK extra.
With a normal topography, would you do a PRK extra?
Normal corneal
topography.
No, I would not do it.
I think that's the point, if you have abnormal tomography or topography, then you can justify yourself for doing it.
That's when you would do it. Yeah.
Or a higher refractive error.
Why should you do extra for a normal cornea,
Anaga, to answer your question, my cutoff for LASIK is 490. For PRK, it's 475. But then that said, I have gone down to like 460, 465 if it was just like a 1 or 2 diopters of ablation and a perfectly healthy topography. So, you cannot just say that you have a cutoff of this much. It's also how much treatment you're planning to do. Now, suppose I'm doing like 4 or 5 diopters, then obviously I won't go down below 475. But if I have like perfectly healthy cornea, perfectly good pachymetry profile and everything, and I will then go 1 or 2 diopters of ablation even with a 460 cornea, right? But for this particular patient with Amjad and Rashmi were talking about, I would be equally comfortable doing both. I'm very happy with PRKs or doing -5 with mitomycin, and I get great results. And of course, I would probably offer the choice to the patient, give him everything about both the options, and I would be equally comfortable doing both.
How high would you go on the diopter for PRK?
So my ablation depth will not cross 80 to 90 microns. I don't go by diopters. I will go by ablation depth, central ablation depth, maximum 70 to 80 microns. And then I would obviously use more mitomycin. But I'm more comfortable staying at maximum of 50 to 60. In an occasional patient, I don't mind going to 70 or 80 microns.
What about 70, 80 would technically mean about 6 diopters, no?
4 to 6. Right. 5 to 6 diopters.
What about Smile in these situations?
I would do a Smile Extra. I would comfortably do a Smile Extra for this patient.
Yes.
Is there a role of Smile Extra at all?
Absolutely.
Yeah.
Okay. No, because it's just that it beats logic. PRK extra is something safest on the cornea. And in that you can do Smile Extra. You've already weakened the cornea biomechanically. So then what are you doing extra? There, I believe extra has no role. Extra has a role only if you're doing a surface ablation.
Literature speaks otherwise. Literature speaks otherwise.
No. Literature is what you and I have written. These extra procedures are only done in this part of the country. So it's not anybody.
What are your thoughts on Smile Extra? especially in this patient?
Which
Dr.
patient?
Rashmi? No, in this patient, would you have done a smile extra, Dr. Rashmi?
No, we again smile for smile, the cutoff is 500 for us. For Lasik, it is 490, and for PRK, it is 470. And
But that doesn't, I mean, it doesn't make sense, like 500 for smile and 490 for
Oh,
LASIK.
they are taking the bed of 10 microns, I suppose.
No, that is not the thing. It's just that we were noticing that smile dissects a little more tissue as compared to LASIK in most of the cases. So the cutoff was made a little higher for smile after that. And smile extra, we stopped doing because we used to not see a very good visual quality. So no extra in smile.
Our rates have dropped down to nothing. These settings which we have. So it's not that we are being radical.
Okay. Now that we are on the topic of phakic IOL, we are running short of time. Just one last question. I can't see Dr. Amrish Tarak sir here. Is he there?
He hasn't joined.
He had in the team. Okay. So we have not touched upon the white to white measurement. So if somebody can just give me just a take home message, Dr. Gaurav, on the ideal way to measure white to white, just for the benefit of our viewers, so that then we can move on to the next.
So for my practice, I would measure white to white with the calipers and with the pentacam. These are my go-to devices today because I see that they are very, very consistent with each other. And other measurement devices like the Almaster 700 and the Lenstar and others will not be as accurate. Either they'll record less or more. So we see very good consistency. So calipers for white to white measurement, and confirm that with pentacam. If I see a difference between the two and they're two taken independently, which means when taking the manual white to white, we don't kind of look at the pentacam and then we look at it later. And if we see a discrepancy, because of what we noticed was that if you've seen the pentacam white to white first, and when you try to go with the calipers, you'll tend to come pretty close to that. Okay. So when we do that independently, then there's no bias, and then we have both of them. And if we notice discrepancy, we go back and measure it all over again and look for any funny landmarks or pigment or something on the limbus which is giving you a false outcome. And that said, again, white to white is only one parameter. We look at the angle configuration, we look at the lens rise, and we look at the AC depth, and we use the NK formulas and other things also today. It's not just white to white that you can use today.
Actually, the lens sizing is dependent on AC depth, the K value, and the white to white.
Yes. Dr. Maipal sir, just one last question. Do you do a UVM for all your patients? Pre-op?
No.
Does anybody does UVM?
No.
Okay. Fine. So let's move on to the next topic. So our next two contestants are Dr. Wavekar sir versus Dr. Sandeep Nagarkar. So Dr. Wavekar, please start sharing your presentation. The scenario is a minus 3.5 diopter sphere with a minus 2.5 diopter cylinder at 90 degrees, pachymetry of 540, normal topography. Topo-guided Lasik is what Dr. Wavekar will be speaking on. He is the director of Wavekar Eye Center in Thane, Mumbai, a very brilliant surgeon and one of the pioneers of refractive surgery in Bombay. Yeah, over to you.
Good evening, everybody. I hope everybody can see my slides and hear me.
Yes.
Thank you, first of all, ARC team, for giving me this opportunity. Very nice debate, very good discussion going on. I'm going to talk on topo-guided Lasik in normal cornea, where the refraction is minus 3.5 diopter sphere and 2.5 cylinder. So it is the cylinder on which we have to, really ponder upon. What is the difference between topo-guided Lasik and Wavefront? So topo-guided Lasik, in addition to the refractive error, treats higher order aberrations. It automatically on its own compensates for angle kappa, which is not the case in Wavefront optimized Lasik. It also compensates for cyclotorsion, which has to be done manually, not by default in Wavefront optimized Lasik. And therefore, topo-guided surgery is really truly personalized as compared to Wavefront optimized Lasik, which is like one size fits all. Now, why we need to treat corneal aberrations? If we see higher order aberrations, the most important source of origin of aberrations is cornea, and the worst of them is the coma. And you can see the effects of coma. The word itself says that it's there is a tail lighting effect, and it looks like a comet, and therefore this needs to be answered. Now, if you look at the origin of the cylinder in the eye, cylindrical power, that means it comes from the anterior corneal curvature, that is the K readings. It comes from the hyaloid aberrations, or we call it talus, and it also comes from the posterior corneal curvature as well as lenticular. And therefore, if we see that the refraction, the cylinder which is shown in glasses is not true representative of the amount of cylinder a patient has. And therefore, all the cylinders needs to be added, not mathematically, but by vector summation method, because we know that they are vectors. They have, unit as well as direction, and therefore, and whatever the resultant has to be treated. And there was a very nice paper by Stulting, RD and all in 2020, which said that retrospectively that when we treat the vector summation of all these cylinders, the results are much better than treating only a refractive cylinder. Now, when we treat this, we know that talus is only at a very specific place on the cornea. It is not a generalized thing, and therefore the treatment has to be given exactly at a place where the talus is. And you can see on the right hand side there is one diagram which shows that if angle kappa is not compensated for, perhaps you'll have a linear shift of the treatment, and the result will be really bad. Whereas if cyclotorsion is not compensated for, you will have a cyclical shift in the treatment, and again you will have a poor result. And therefore, it is very, very important that we do the registration and compensate for these two factors while doing topo.
Dr. Wavekar, we can't hear you.
He got frozen.
Hello, Dr. Wavekar?
It was a very good talk he was giving.
He'll come back, don't worry.
He just got it.
He went too much in one direction.
I think you just became too lucky.
No, it looks like he had a power cut, so his presentation is frozen. He'll probably come back in a few seconds.
Yeah.
While he comes back, Dr. Chitra,
yeah.
While he comes back, I just wanted to ask you that if you have to do a high hyperope, like with angle kappa, and you are doing a topo-guided, and see Contura doesn't allow, and Dr. Nagvekar is there, and Tithyal sir is there. And if you're using the Wavelight platform, you will not get, on topographic guided is what is supposed to be treating on the visual axis rather than on the center of the pupil, so avoiding the angle kappa. Then, but Contura frankly doesn't allow it. Does FCAT allow you to treat on the visual axis, or that treats on the center of the pupil?
He's got disconnected. He's joining again.
Sure.
Oh,
so this is very.
I don't use FCAT. I do Contura. I do Wavefront guided, and I won't treat high hyperope.
For hyperope, okay, small hyperope, 2 diopters. Would you do a Contura, or you would just do a Wavefront optimized?
I would do a Wavefront optimized.
But that will treat on the center of the pupil. Will you decenter
the pupil
and angle kappa?
Ideal, but Contura, are you able to treat hyperopes?
That's exactly what I'm asking. So that's what I wanted to ask you guys.
So
if you want to treat on visual axis, see, we keep talking about topo-guided treatments on visual axis for hyperopia, but how do you practically do it?
No, but
Dr. Wavekar, you have joined. Yeah, please start.
Sorry, I don't know how I lost the connection. Till what time? Till what time you heard me?
You were frozen in time.
No. I'll tell you. You were telling us about angle kappa, how it gets deviated if it is angle kappa is not taken
angle
into
kappa and
cyclotorsion.
Yeah. So the basic thing is that if you 1 second, I'll start with this.
Yeah, from the next slide. Number 8.
Fine. So if you have to, it is very mandatory to treat angle kappa and cyclotorsion also. And there is an elaborate algorithm nomogram. The US FDA studies which was done, it was done on basically very small subset of patients, and the results were very good. And there was a period in between where we did not know exactly how it was working. But now the plane has steadied, and we are very confident about the result. There is definite improvement in the quality as well as quantity of vision. Patient satisfaction level is very, very high. And therefore, whenever a patient has high cylinder, I think there is no doubt that topo-guided PRK is the way to go. Thank you.
Yeah. Thank you, Dr. Walkar. Great presentation. Dr. Nagvekar, can you start sharing, please? So, Dr. Sandeep Nagvekar sir will be speaking to us on how Wavefront optimized Lasik would be the procedure of choice in these patients. He is an excellent surgeon, one of the pioneers of refractive surgery, and a great cataract surgeon too, with lots of experience, and one of the leading surgeons in Mumbai. Yeah, over to you.
Well, my friend has actually made my job easier. He's not looked at what you've been presented. So you're looking at a -3.5 sphere with a -2.5 cylinder at 90 degrees. It is against the rule, something which my friend has forgotten about. The Phakic is 540 and you have a normal topography. Now, I don't need to go into this. All of us know that when you do a topography guided contour ablation, you are basically treating the corneal surface based on the topography of the anterior cornea. It seeks to eliminate both the lower and higher order aberrations based on the scans. And for astigmatism, it treats the topography measured astigmatism, both in terms of magnitude and direction. Whereas when you look at Wavefront, it optimizes the aberration profile of the ablated cornea by selective peripheral ablation. It minimizes the induction of newer higher order aberrations, especially spherical aberrations, and it treats the manifest refractive astigmatism rather than TMA. Now, why is this important? Because if you look at the literature and if you look at the results, if your topography manifest astigmatism, measured astigmatism is greater than the MRA, Contoura works well, especially in cases of with the rule astigmatism. If the TMA and the MRA are equal, then either of them works. And if the topography measured astigmatism is less than the MRA, the Wavefront optimized Lasik works better. TMA does not take into account the internal astigmatism, which is coming, as he himself elaborated, from the PCA, the lens, and other things. What happens in against the rule astigmatism as it in this case? Here, the PCA is always against the rule. Hence, the TMA is always less than the MRA, which makes Contoura undesirable in cases of ATR. Lenticular astigmatism also plays a major role, and I'm going to show you a slide to show you that. And very often, the TMA axis does not coincide with the MRA axis. Now, here is a case which is ideal, because here is a case from one of my own series where this patient had -2.25 diopters of astigmatism against the rule, very much like the case we have given. And just have a look at the anterior corneal astigmatism. It is 1.4 diopters. And 0.2 comes from her posterior cornea, which means that nearly 0.6 or 0.7 comes from the lens itself. And how are you going to treat that with a topography guided thing? Because to use a TGCA, you therefore need to compensate for the difference, either manually or use third-party software such as the 4CDs, which is not an open source, or the iSmart software provided by Zain Khatib, both of which are not officially approved by the manufacturers and developers of the TGCA. The ideal treatment in this case is therefore never a pure TGCA, even if you are doing it. And here are some papers compared, and there are many of these papers which show that basically at 3 months, if you do a Wavefront in one eye and a Contoura in the other eye, there is no difference in the process as far as the best corrected, uncorrected distance visual acuity is concerned, and with the residual refractive error. Though, yes, the higher corneal aberrations, especially the coma, as he alluded to, is less in the topo-guided group as compared to the Wavefront optimized group. However, there are other studies which also show that if you treat the topo-guided treatment and you treat only the anterior corneal astigmatism, then very often there are inferior outcomes because you have ignored the residual astigmatism which is internally. Also, as far as the axis is concerned, as he himself showed, if your axis is, if your astigmatism is more than 2 diopters, then you cannot tolerate more than a 5-degree diopter difference between the topography measured axis as well as the refractive axis. Another important component which is very often forgotten is how much of the dry eye contributes to irregular astigmatism, and that has been elaborately proved in many papers across the globe. And therefore, the topography scan becomes a little problem because this dry eye, which very often these contact lens wearers have, is a problem because when they come and you do the scan, Many often you are measuring higher errors than they have because the dry eye is affecting the quality of the scan. The scan quality is impacted by the tear film quality. Most of the time, they have been wearing lenses for a long time, just discontinued before they come here. And therefore, you need to optimize the surface prior to scan acquisition, which sometimes takes 4 to 6 weeks. The problem is that our contact lens wearers do not want to do LASIK tomorrow. They want to do it yesterday. Very often goaded by their parents, we want to go here, we want to go there. So are we really taking the scans in the proper way? What are the calculation headaches? You need a separate topographer to export the normal higher order aberrations that can be measured by any other topographer. You need to compensate first for the spherical aberration induced defocus for treatment of higher order aberrations. Central ablation 4 microns, peripheral ablation 14 microns. You need to compensate for that. You need to do a C4, C12 compensation on the Zernicke polynomials. If the TMA and MRA do not match, you need to compensate for the same. That means if your topography measured is 2 diopters and your refractive is 1.5 or 1 diopter, you need to compensate for the same. You need to further compensate for the spherical equivalent of the manifest refraction. Therefore, compromises easily creep into the system almost at every stage, right up to the final calculations. Now, look at these two gentlemen. Neither of us resemble them either in looks or in IQ. Whereas look at Wavefront optimized. There's no need for any further calculations beyond a pristine cycloplegic refraction. Dry eye management, unless highly significant, can be initiated a week or two prior to WFO ablation and continued thereafter. Treatment can be centered on the visual axis or compensated for angle kappa by iris registration and pupil tracking. Yes, it is possible that even with WFO, you can make some compensation for angle kappa. And pre-existing higher order aberrations do not worsen after WFO and do not impact the patient's routine lifestyle. So look at this case again. Normal topography, adequate pachymetry, and a 2.5 diopter cylinder at 90 degree minus against the rule. You choose what you want. I rest my case.
Beautiful. Absolutely amazing presentation, Dr. Nandekar. I think he's made it all the more clear and great clarity into this. And I think today's word, the first question is Contoura a hype? Is it more pushed by the patients because of digital marketing, or is it truly something really better than Wavefront treatment? Dr. Mahipal sir? Is he there?
Is there?
Okay. Dr. Chitra ma'am?
See, it does take measurements over a very large area in Contoura vision, and Wavefront was doing very well. After all, it's all part and parcel of the same package. But Contoura, centered on the visual axis, we are very confidently able to treat high cylinders, and the precision is so repeatable and consistent. You could actually be 200% sure that you can promise your patient and you will deliver it. So actually nowadays, higher cylinders, I don't do on Smile, though I was doing very well with Smile when Contoura was not there. But the consistency which is there with Contoura, that with no small cylinder there anywhere in the flash value or in the refraction in Smile, it's constantly plano. So definitely a whole lot of points are being analyzed on a Contoura map, and that too with the 4 cities software which we had, we were able to, understand that there are so many aspects, nuances when you're doing high astigmatism, and how the entire the vector analysis was so critical. So definitely we cannot, as we are advancing, we need to incorporate that. Wavefront was doing very good. Our earlier Lasik was doing very good, but we have to move on because we have gone to a very high level of accuracy. We need to deliver what we promise our patients, and today we can.
Why was, ma'am, is no, we are still doing good. Dr. Gaurav, just one question. Now, Dr. Nagvekar sir put in so many variables. So you have the Contoura, but do you use Contoura for all your patients, number one? And second thing, because I've heard a lot of people saying that they use it, say, in 30-40% of patients only. Second thing, in what cases it can really go wrong in spite of all the calculations? And do you really need it for those who don't have it?
Okay, so I think Contura is excellent. I enjoy doing Contura, but as Dr. Chitra said, patients with high astigmatism and, those outcomes have definitely improved ever since we started doing Contura, especially with the 4 cities planning. It really helps because it takes into account, not only the measured astigmatism, but the manifest and then the axes. And, if all that aligns up, 4 cities actually is like a nomogram, which makes life very simple because it takes into account many things and just gives you a good, thing. You can do that otherwise also, but it will waste a lot of time. And Dr. Nagvekar really nicely explained, the where it really actually works and where it may not really be required at all, where Wavefront Optimize will work beautifully well. So there is no role for Contura in every patient. It's only in a small subset of patients where Contura will work really well, and you have to know where to use it and where not to use it at all. And believe me, when somebody says that I've done 100 Conturas or 200 Conturas in a day, it's absolutely very, very difficult to do that because it takes a lot of time to do planning and measurements for Contura treatments. They should not be done unless you've gone really in depth about the Contura planning. That said, now I think there was one question which I wanted to put to Dr. Nagvekar because he did mention, and I believe I agree with him. And in fact, Dr. Vavekar, because you can do cyclotorsion registration with Wavefront Optimized for what you were trying to say, that you want to do topo-guided mainly for cyclotorsion. I think you can do it with FCAT. You can also do it with Wavefront Optimized with iris registration. What I don't understand, Dr. Nagvekar, is that whether you can do a switch to a visual access treatment rather than, like you said, you can decenter it automatically. I don't think so. I think Wavefront Optimized, even after cyclotorsion control and everything, still fires on the center of the pupil. It uses the pupil tracker rather than firing on the apex of the cornea or on the visual axis. So I don't think that holds true. You will have to go to topo-guided treatment if you want to treat on the, automatic compensation for angle kappa. Maybe Vavekar can tell us a little bit on this.
Yeah, see, what I said about angle kappa is that it will ask you how much you want to shift in Wavefront Optimize, 50%, 75% or 100%. And even the company people recommend 75%. So from where this 75% number has come, God knows. So it is arbitrary. As far as the cyclotorsion is concerned, suppose in a patient you fail to get registration, you just cannot do Contura. But if you fail to do a registration in a Wavefront Optimize, that means you are bypassing the step of cyclotorsion, and then you can go ahead with Wavefront Optimized Lasik. That is what I meant. Okay, when it is Contura, this is must. You just cannot move ahead. Whereas when it is Wavefront Optimized Lasik, yes, it is possible to do that.
Vavekar, are you trying to say the machine will not allow you to move ahead, or you should not move ahead?
No, it will not allow you to move ahead. Without
it does allow you to move ahead, actually.
It does.
It allows you to move ahead, but you should not move ahead because you're doing a topography guided, where ideally you should not be moving.
Can you do Contura without registration?
Yes, you can override it.
You can do without registration.
You can do, but the problem is you should not do when the cyclorotation is more than 10 degrees. It has to be less than 10.
Yeah.
Anyway, also, on the visual axis makes sense. Whether
I think we are boring the non-wavelight users. I think we are boring them because we are talking all jargon.
So that question,
but it's very interesting, Anaga. Yeah.
Yes. So even without wavelight, we can go ahead and do.
I know you guys can do exactly the same thing on your platforms. We understand that.
Ashwin also can do.
Vavekar, does FCAT allow you to correct for cyclotorsion in addition to firing on the visual axis, or that will also fire on the pupil center? Quick question. One line answer.
Pupil center.
Yeah, right. So the only way to treat a angle kappa automatic compensation is to go to topo-guided.
Correct.
Okay. Yes. Thank you so much, everyone. Now we'll move on to the video session. Dr. Deepti, are you here? Yes. So Dr. Deepti Meda, she's the Director and Consultant Cornea Refractive and Cataract Services at Karthik Netralaya, Bangalore. And she would be speaking to us on management of lapsed eye. So we have had an excellent discussion in the debate session. So these are now video-based inputs and contributions from our speakers. Right. Go over to you, Dr. Deep.
Thank you. Thank you so much, Dr. Anaga, entire ARCAOS for yet another opportunity. So yes, these are the grooves which we certainly would not want to see after a Lasik. So a quick video presentation of this patient of mine. 24-year-old girl, very happy for the first 2 weeks. And then she calls me after third week, my vision is not as great as it was yesterday. And this was something we suspected even on phone and called her immediately. And her vision was okay, six parts. The only thing she noticed was a little glare and halo as compared to the other eye. A very positive girl, very optimistic. So it was already 3 weeks, and through photos we discussed what are the pros and cons, and together we decided ki yes, we will have to plan and manage this for better vision. So there are not too many strict protocols, but there have been quite a few case series in literature on this topic. So basically the 5 rules when you want to treat staph striae. One is to release the adhesion. Second is to swell your flap. Third is to iron out your flap. And fourth is for long standing, especially 2-3 weeks, heat is a good way. And also to stretch the striae. So we applied all these 5 principles in her, and let's go through the surgical video. The first thing is the golden mantra. We all know the epithelium has to go out because it's 3 weeks, and that's the one which is anchoring all the folds. So not only on the flap, even at the flap margin, it's very important because you don't want any epithelial ingrowths. We could also use alcohol to kill over the residual cells because epi ingrowth is higher in flap reliefs, and that is something you don't want to do. And floating is very important. Be very generous on floating your flap. So you will have to hydrate or swell the flap in order to release this chronic striae. And again, the next would be ironing. There are a lot of methods described. A simple surgical sponge, which is semi-wet, perpendicular to the striae. It's just that in these striae, you should be very patient. Put some nice music for yourself and the patient and go on. It just goes on. And you're never satisfied when you start doing it. So the next application, which was very useful in this patient at least, was a heat application. So here we used very good quality stainless steel hockey sticks. And see, your main target is in the visual axis. So make sure your visual axis is at least free of the striae. And fifth, again, a very important one for chronic striae is you will have to stretch and anchor it there. So we put in 3 sutures for this particular. Again, this step is depending on the time they're present and what grade the striae is. But this is something that we opted to do for this patient. So this was her end of the surgery. So there are so many ways of applying heat. You can put it in 65 degrees Celsius sterile water. And this is a very simple technique. You can slightly heat it up, gauge the temperature. You could also use a non-touch thermometer on this to see what is the temperature at sea. It's a very personal choice. You just don't want a very hot one where you can shrink the collagen. A little warmer than lukewarm is something that we generally prefer. And this is on week 1. And this was pre-op. So coming to a few trips during surgeries, as you see here, when you don't have a retroillumination, there's nothing that you see. The flap looks beautiful. So the entire surgery has to be done with a dilated pupil. That's only when you'll appreciate these striae. That's the first thing. Second thing is epithelial removal, very, very important. So this was histopathology where you see how it is anchoring on the fold. So unless you get rid of all these epithelium, you won't be able to release these striae. And next is swelling. As I said, be very generous, and you will have to balloon up or swell up your flaps in order to sort of relax your striae. And mainly target your visual axis. You really don't have to run behind a peripheral striae, but mostly you're trying to improve the visual comfort of your patient, and always try to target to release as much striae from your central 5 to 6 thing. If you can get rid of all of them, well and good. So most of your maneuvers should be such that you're trying to do it. Now, whenever your cornea is wet, we know the cornea looks so smooth. It's only when it is dry that you really can appreciate it. So whenever you feel you want to check in, make sure you dry it, look into the striae, and again, go back doing your massage or heat application. So as soon as I put saline, see how pristine the cornea looks. So the flyer absolutely not see when your cornea is wet. So keeping a dry, dilated pupil is very important. Now, endpoint is something important. You will never see an endpoint where you see a smooth cornea on the table. So you will have to judge based on experience when is the endpoint. So this was the endpoint during surgery. There was still some striae, but I'll show you the post-op. So you really don't have to target to get a smooth thing, but you will have to ensure that the intensity of the striae are appearing much lesser on retroillumination. So this was the endpoint of surgery. So it's a very slow patient surgery where you have to go on, and this was on week 1. So you see the central striae are totally gone. The only striae I see are peripherally, that too because of the suture in place. And this is again a retro image at 1 week. The visual axis is perfect. And this image says it all. So this was her OPD scan where you can see the higher order aberration, which was actually bothering her. It was not much of a refraction that is there. It is nicely reduced to 0.3 with a very clear cornea on retroillumination in the 6 to 7 diameter. So happy patient, end of it.
Great, great. Lovely presentation, Dr. Deepti, and very well covered. So the point here is use of hypotonic saline, which is very important, not just plain saline. So one question, Dr. Maipal sir.
Yes.
This was a 3-week-old case, and obviously she used epithelial removal. But if it was 1 day post-op, would you need it? And what would be the cutoff? Where would you do an epithelial debridement?
So basically on day 1, you don't need anything. You don't even need to remove the epithelium. The epithelium essentially why you need to remove is that the epithelium acts as an anchor on the ridges that have been created. Until you remove those ridges, the cornea won't swell up. And as you just said right in the beginning, using hypotonic saline. So normally I put 1 drop of distilled water and 1 drop of BSS so that it becomes hypotonic and let it swell. So that you have to see on the whether it's a microstria or a macrostria. So if they are dense, thick stria, then anything more than I would say 4 to 5 days would need an epithelial to be removed. So it's basically your clinical judgment that the anchorage, how strong is the anchorage that is there for the ridges that have happened. But epithelium removal in long-standing cases, like she said, 2-3 weeks. The only question I was slightly surprised was that she had good vision for 2 weeks and she complained of loss of vision. This is not a case where these strias have come after 2 weeks. This has been there right from the beginning is my thought process. I don't know, Dipti, would you wish to clarify? You said that the patient had good vision at 2 weeks and then went down.
So 1 week is when we saw she was good, but I think one thing that might have happened is she's not noticed it. Maybe then she's probably closed one eye, and that's many a times how these people come in. So she might have just closed one eye and then realized it, but that's the first time she actually noticed the symptom. Till then she said.
So typically you don't. Yeah, so basically, typically you don't have macrostria developing by rubbing or something until, of course, in that case, it should be some kind of a trauma where the flap has got dislodged. But anyway, leave that aside. But to answer your question, 5 days, I think 4 to 5 days. If they've been there, then I would want to remove the epithelium. The quantum of epithelium removed is also going to be determined on where all these stria are and how thick these stria are, macrostria or microstria that are there. But hypotonic saline is essential. And one thing that I wish to re-emphasize is that these strias do not disappear on the table. Yeah, they will become much better as time elapses because you are allowing the whole thing and it kind of keeps on swelling and smoothens out as it is. And normally I don't mind putting some form of glue because there is so much of manipulation, there is so much of swelling that is there in the stria removal that the adhesion of the flap in the periphery obviously is bad and the chances of epithelial ingrowth are pretty high.
Dr. Titial sir, one last question. If there are microstriae in the visual axis, patient is not complaining, would you touch it or no?
If patient doesn't have the problem, if the visual acuity is good, microstria, you may not handle them, you can just leave it like that because that's not going to exactly disturb the visual path for a person. But yes, if it is causing some sort of a decreased vision and induction of higher order aberration, you might. Otherwise, sometimes lifting the flap is going to give another chance of complications.
No problem.
So I would rather wait and watch, see how patient does. Microstria normally don't intervene.
Yes. Thank you, sir. So moving on to our
one thing I like to say, like Deepti has shown a beautiful, surgical videos, nice steps. But I personally towards the end, I normally put contact lens in these patients and leave them for a slightly longer time.
Yeah,
yes,
always.
Always.
Thank you, sir. Our next presenter is Dr. Sujata Mohan, ma'am. She's the Executive Medical Director, Rajan Eye Care Hospital. Excellent phaco-refractive and corneal surgeon with more than 20 years experience in refractive surgery. Absolutely brilliant surgeon and great academician. she'll be speaking to us on the lost flap. Over to you, ma'am.
Thank you. Thank you, Anaga. And I'd like to thank ARC for giving me this opportunity. So,
hello.
Are you able to hear me?
Yes, yes, ma'am. Your slides are seen. Yeah.
So lost flap, is it completely lost? Let's see what happens. This was a 20-year-old female with a refraction of -5, keratometry of 43-42, a normal topography and pentacam, and a normal pachymetry. And this was one of my very early cases when I just probably started Lasik. It's about more than 20 years. And I was using the Moria microkeratome. And I think there was some mistake I made in the calculation of the stop. And you can see that when I lifted the microkeratome, you can see that there is no flap. Fortunately, I had the foresight to look for it in the microkeratome itself. So it is there on the microkeratome head. And I tacked the flap, continued with the laser. And after completing the laser in the usual protocols, now I'm removing the tackwood flap and putting it on the bed. So here the most important thing is tackling the flap is important because then you know which side is epithelium, which side is stroma. The other important thing is pre-placed marks are there in the cornea, which is going to help me to realign the flap absolutely properly, because some of these free caps have no hinge. They're exactly round. So unless you have pre-placed marks, it may be difficult to align them. So even till date, when I do Lasik, I still continue to do, I do place pre-placed marks. And once I've done this, I just waited for 5 minutes, made sure that the gutter is even all round. And after waiting for 5 minutes, I put a bandage contact lens. And I have about 20-year follow-up on this patient, and the patient is doing extremely well. And I really don't even know which eye had the free flap. So the most important thing in this aspect is how not to lose the flap. If you panic, you don't see the flap, the most common place that you will see is on the microkeratome itself. So the tips are tack with the flap, alignment done on pre-placed marks, make sure of an even gutter all round, dry the flap for 5 minutes and apply BCL or suture the hinge. So the next case is again a free cap. This was by an Amadeus microkeratome. You can see that the flap, once it comes back, you can see that it is not, there is nothing there. And just searching for the flap, so nothing to be found there. And again, it was on the microkeratome itself. So this is one point that I think all of for beginners you have to remember. And in this case, I just placed it on the bed, just like as I would do when you lift the flap. Continued with the laser and put the flap back. Again, for me, the advantage is that I already have pre-placed marks and align the flap very absolutely to the exact to the aligned mark. Taken my time to do it. Wash gently underneath the flap. Make sure that the flap is not twisted. And also make sure that the gutter is even all around by drying it. And then again, in this case, also avoided doing a suture. Of course, you can suture the hinge, but suturing the hinge may be a benefit, but also can pull the flap towards one side. So that also has to be taken into consideration. And applying a BCL is very important because even if the flap shifts, the chance of it moving away can be protected by the BCL. So this is one thing where you do not lose the cap. So if you don't put a BCL, there's a chance of flap loss. So the incidence of free cap is about 0.004% to 1.31%. And the causes of free cap are flat corneas, deep orbits, large corneal diameters, tearing of the dehydrated flap. Mechanical causes can be incorrect assembly of the microkeratome, torquing of the flap, failure of the stop mechanism, and reduction in the intraoperative pressure. So the complications which can happen are flap can be placed upside down, and this can be prevented by tackling the flap. And also you can identify the epithelial side by staining, in which the stromal side stains more than the epithelium. Loss of disc is again another major problem which can be prevented by placing a BCL over the free cap and suturing the hinge. Astigmatism can happen if you have not aligned it properly, and you can get irregular astigmatism. So reorient the correct position, pre-op marking to help the alignment, And if everything has gone wrong, you can go in for a topo-guided or Wavefront-guided laser. And again, the other important aspect of a free cap we have to look at is the epithelial ingrowth, which is will be a big bugbear. And some people prefer to suture the hinge, and it's very important to place a BCL to prevent it, and also to make sure there is a correct orientation of the flap. And last but not the least is the flap micro and macro striae, which we've all discussed. And so striae removal has to be done in these patients. But again, this is very difficult in these patients because floating the flap is going to be difficult. And if the striae are very dense and causing a loss of visual acuity or ghosting and glare, then you can do a flap replacement from the donor. So tips for prevention are corneal diameter and keratometry has to be looked into. The stopper should be checked before every procedure. Each microkeratome has its own parameters, so make sure that you know the microkeratome well. Make sure you have adequate suction. Use pre-placed corneal marks. Patients with very flat corneas anticipate a free cap, and use of femtosecond laser prevents this complication. Now, I think most of us have shifted to femtosecond laser, and almost only about 20% of refractive surgeons are still using a microkeratome. I think more and more of us have to shift towards femtosecond laser because it does prevent most of the complications associated with microkeratome. Thank you. And once again, thanks for the wonderful opportunity.
Lovely, lovely presentation, ma'am. You've covered everything and all aspects of it. One small thing was to define the epithelial side up. You can also probably abrade it a little bit at the side. So only the epithelial side, obviously the superior side would abrade, not on the stromal side. Second thing, just a question. Sorry?
The stromal side will be sticky also.
Yes. And yeah, it will not shine as much. So one question is, does everybody use a contact lens in a routine case for all LASIK procedures, whether it is blade or femto? What is the consensus, whether to use a contact lens for every case?
No.
Yes or no?
No,
No.
I would not. But I do know some people who do use it routinely, but I don't.
Some people use it routinely. Yes, number one. Second thing is, there was a case where there was a free cap and they had used a contact lens. When would you remove the contact lens? Would you remove it immediately the next day, or would you wait for a day or two more?
Wait for a week in these patients.
Week, yeah. One week. 1 week.
1 week, yeah. So there was a case where somebody had put it, and when they removed the contact lens, the disc came out along with the contact lens. So was it because it was removed early, or is there any other reason?
It can be either upside down, or it was,
Yeah.
they slided the contact lens off. If you don't kind of take it off from the edge and just lift it up, if you try to slide it off the cornea, then you can slide it off. But otherwise, most likely it's because the flap was put upside down.
Upside down, right. And one last question is, Chitra ma'am, suppose you had a case like this. Number one, what special precautions would you ask the patient to take? And number two, how would you explain to the patient? Or would you not say anything if you think you have put it properly? Would you not say anything at all?
I might not crudely tell that you've had a free flap, but I would definitely tell them that the flap is not adhering well. So a contact lens has been placed, so you just should not be touching your eye. And we would even put an eye shield for these patients and ask them. Normally, I don't even remember whether we still use eye shield in our post-op because, I mean, there's so many down the line. But in those patients, I'll tell them to use an eye shield for at least 5 days till the BCL is on.
Eye shield at night, huh?
Night.
So, answering your question, I think it is always wise to tell the truth to the patient, because post-operatively, anybody can on the slit lamp make out that this is a free flap or it is not a free flap. And if you are tomorrow taken to court, if you have not given the correct information and you have not told the patient, and it is proven that you have given an incorrect information, you are obviously going to be in a suit. So never ever I would deny the patient the right to know that yes, there has been a complication, it can happen, and there is a free flap and we have done it and it has been replaced and we have put a contact lens and you need not rub, etc., etc. And it will possibly not have any impact on your final visual recovery, because you will get a scar at the free flap also, which you can see easily on a slit lamp subsequently.
Yes. Thank you. Thank you so much, sir. I think we have covered almost all aspects of it. Thank you, ma'am, for such a lovely presentation. Sorry?
I said excellent talk, Dr. Sujata.
So we move on to the next video. Dr. Vikram Vaidi, please start sharing. He's a consultant cornea, cataract and refractive surgery at Anila Hospital, Mumbai. He's been trained at Arvind Eye Hospital as a postgraduate fellow and as a senior consultant. So he'll be speaking to us on epithelial ingrowth. Over to you, Dr.
Thank you, madam. My slides visible, ma'am?
Yes, yes. Yeah, please go on. We can't hear you. We can't hear you, Dr. Vikram. Hello? We can't hear you. You're muted. Please unmute.
It's a pre-recorded presentation. I think you'll have to share it as a video.
We can't hear the audio. You can start speaking in it. Yeah.
Dr. On the status bar, there are 3 dots. Just click on it. There is an option called share sound. Just your sound will be covered. On the status bar, on the floating bar, 3 dots, share sound.
Of the session today. Prior to the video, here is a short summary of the patient.
We can hear.
30-year-old male. He presented 10 years post-refractive surgery with defective vision in the left eye and noticing a white spot since 2 years. BCVA was 6/60 with 8 cylinder, and as you can see, a dense white confluent epithelial ingrowth involving the flap edge as well as the pupil margin. Pentacam was suggestive of an irregular astigmatism corresponding to the area of the ingrowth. These are the OCT images showing the epithelial ingrowth. Management options, grade 1, which are thin, non-progressive, close to the flap, can be observed. Grade 2 and 3 are usually progressive with varying involvements of vision and the flap, hence require a flap lift and scrape. ND-YAG as a treatment option, useful for peripheral localized ingrowths as well as recurrent cases. And final options remaining is flap amputation and a keratoplasty. So this was our patient with a dense ingrowth involving the visual axis and producing irregular astigmatism. The plan was to do a surgical flap lift. The corneal surface was marked with the alignment marks due to increased risk of intra-op flap related complications. The epithelium at the edge of the flap was scraped. The flap edge was carefully delineated and the flap was lifted. Once the flap was lifted, the areas of ingrowth, especially on the stromal bed as well as on the undersurface of the flap, were meticulously and aggressively scraped using a dry Mirocell sponge, a hockey stick, and a 15 number blade. As you can see, the areas of ingrowth on the undersurface of the flap were quite adherent and they were also aggressively dealt with. The flap was washed and dried a couple of times to look for any residual areas of ingrowth which can act as areas of recurrence post-operatively. Mitomycin C was then applied to the stromal bed as well as the flap undersurface using a Mirocell sponge. 0.02% was applied for 1 minute. The flap was then thoroughly washed with 30 to 40 cc of saline. The flap was then refloated. The flap alignment was then checked with the peripheral marks. Now, in order to ensure a tight seal with the flap edge, 6 interrupted 10-0 nylon sutures were applied all along the flap edge. Finally, fibrin glue was also applied to the flap edge to get a tight seal. Antibiotic drops and a BCL was placed. Patient did well in the post-operative period with an improvement in the BCVA as well as in the corneal parameters. Suture removal was done at 1 month post-op. These are the densitometry and OCT images. At 3 years post-op, BCVA was 66 parts with no recurrence of the epithelial ingrowth. In the surgical management of an epithelial ingrowth, a meticulous pre-op evaluation to assess the flap edge, the extent of the ingrowth, Pentacam and OCT are useful in the pre-op as well as to monitor post-op recurrence. Prior to flap lift, an idea about the flap orientation and being prepared for flap complications is useful. Meticulous, aggressive scraping, removal of the fistula strand, use of MMC, and achieving a seal using sutures and glue. All of these measures, when combined together, can help reduce recurrence and also achieve anatomical and visual outcomes that are acceptable. Thank you so much for your time and patient hearing.
Great. Lovely presentation, Dr. Vikram.
Thank you, ma'am.
Very nice. Dr. Tityal, sir, are you there?
Yeah, I'm there.
Yeah. Sir, I would like you to enumerate what are the tips for our benefit of our viewers. What are the tips to avoid having epithelial ingrowth so that we avoid having such situations at all?
Yeah, first of all, it was a beautiful presentation, and Dr. Vikram nicely highlighted every step to manage these epithelial ingrowths. Yes, we can prevent epithelial ingrowth happening in these cases, like primarily repeated use of microkeraton blades that should be avoided. And we know that any epithelial defect during your procedure and resurgery is one of the most important cause of epithelial ingrowth happening in these patients. Patients with some sort of epithelial or basement membrane dystrophies like EBMD, they also have a high chances of epithelial ingrowth happening. So surgically, the right selection of cases and intraoperatively meticulous cleaning of underneath surface. What we normally practice, you can float the flap after you complete the ablation with one cannula. Then we go the next different cannula inside the flap to clean the debris there. So you avoid epithelial cell going inside the eye, and make sure that your flap is nicely apposed in these cases. If you have some sort of epithelial defect coming up in your cases, you must put a bandage contact lens for better apposition for that primary case. But most important risk factor is repeat attempt of relifting the flaps for a retreating sometimes or some sort of other problems. Otherwise, normally we hardly see epithelial ingrowth happening in these cases, especially the femtosecond laser flaps. I've not seen epithelial ingrowth happening in these cases. So shifting to femtosecond flap making is also a better way to handle Lasik patients.
And, excellent.
One thing is never to lift an old flap to do an enhancement. Yeah. It's best to do PRK beyond 3 years.
Dr. Maipal will differ.
No. Maipal and I have lifted many flaps in our earlier days and we've not had epithelial growth, but those very rare occurrences are no longer there at all because we don't lift the flap. That's what I meant.
But as far as Dr. Chitra or experience, doing a PRK on a flap, yes, the outcome is not that predictable. On a PRK in any other, not in a primary eye, secondary procedure as a PRK is not very predictable.
Patient comes after 5-6 years with a residual error.
No, we have lifted the flap even after 10 years also. It comes up very.
Yeah, this patient was 9 years. It was lifted very.
But we don't tell the people who are hearing us now that we will lift the flap which is 10 years old.
Why?
Because
the flap never heals, they say.
Because there is those very rare occurrence of epithelial ingrowth. They have to develop the epithelium quite a bit around the margin of the flap, and they have to be very meticulous.
Well, you can have haze in PRK.
I have not had.
And the first thing as Dr. Tityal was saying is you are ablating at the same location. You are ablating at the same plane. You are not creating two separate planes for ablation. In one, you are there's a stromal ablation that has happened. In the other, you are doing a surface ablation. And that in itself is not the best way to treat a residual refractive error. If your flap is good, and a 15-year-old flap would have been done by a Hansadome, which would be 160 microns thick. So normally thick flaps adhere very well. And it is, first of all, I would always do an OCT today and check the thickness of the flap as to how thick or how thin it is, and then accordingly do that. See, if you have a very thin flap and doing a PRK on that for a slightly higher power is going to be also going to be counterproductive. So
Again,
let us not go with a message that you should not lift flap. That is entirely the prerogative that if you put a bandage contact lens there at that particular time, you do not get epithelial ingrowth. Yes, chances of repeated lifts going in for epithelial ingrowth are higher. A recut is always better, but a microkeratome flap doing a recut can also be fraught with sliverings, which can cause a lot of irregularities. So in my particular case, even at 15 years post-op, I have lifted flaps and got away very well doing the ablation at the same plane rather than creating a new plane.
Yeah.
I would not lift the flap. I would lift the flap if there is epithelial remodeling and the epithelium has become very thick. So if I go back and do PRK as an enhancement in those patients, then again, there could be some residual. So then I would lift the flap. But otherwise,
I would like to caution also about hyperopic LASIK enhancements, because there the risk of epithelial growth is very high.
Much higher,
and they are the ones which are likely to have more regression anyway. So there the chances of re-enhancements is much higher. But then because of the peripheral guttering, the chances of epithelial growth are very high, and you have to be very, very careful.
Yeah, and in those cases, even relifting becomes difficult because they at the paracentral area,
So why can't we just glue it when we relift it?
Yeah, you can. That's what I said. You can put a bandage contact lens and glue. You can do that. There is a higher incidence of epithelial ingrowth in relifting. That is known. But it is not that every relift is going to get into an epithelial ingrowth.
That's not.
Okay. Thank you so much. It was a nice discussion. So we move on to the next video. That is Dr. Raghav Malik. Is he there? Dr. Raghav? Can't see him here. Okay. Dr. Riddhima?
Yes, ma'am.
Yeah. Can you start sharing? Yeah. So Dr. Riddhima Bagli, she is the Director, Pioneer Medilaser, Pune, Cataract and Refractive Surgeon, Fellow Anterior Segment, King's College Hospital, London, and Fellow Cataract Refractive Services, NN, ex-consultant of Narayan Nethralaya, and her area of expertise is refractive surgery, relaxed smile, and challenging cataract surgery, along with phakic IOLs. Over to you, Doctor.
Thank you very much, ma'am, and thank you to AIOC ARC for this opportunity. So I'll start my video. It's pre-recorded. Please let me know if you can't hear the sound.
Complications of phakic IOLs are rare, but we need
the music is very high.
Okay.
To know how to tackle them.
Background music sound is very high. We can't.
Starting with the intraoperative complications, wherein upon injecting the ICL, one notices that the ICL has flipped over. No attempt should be made to flip it over in the anterior chamber. The ICL needs to be explanted and reloaded. With a sustained pull, the ICL folds over and can be extracted through the same corneal wound. An inverted ICL implantation will cause lens touch and development of cataract. While injecting a phakic IOL, one needs to be slow and watchful of the orientation marks on the lens. Rotating the wrist or using a second instrument as a guide can help in correct orientation of the phakic IOL. Here the IPCL has opened the wrong way up. Here the main wound is being extended to allow for an easy explantation of the IPCL. Post-operative complications, common would be a residual refractive error. First, ascertain proper alignment and vaulting of the lens. Treatment options include rotating the ICL based on a vector analysis, or top-up laser, or exchanging the ICL. Sometimes we may end up with an oval post-operative pupil with a tiny optic capture. Constricting the pupil at the slit lamp like shown here or pharmacologically can usually do the trick. A Appropriate measurements are crucial for correct ICL sizing. High vault more than 1000 microns can lead to pupillary block, narrowing of angle, pigment dispersion, and glare. A low vault less than 250 micron increases the risk of an anterior subcapsular cataract as seen. Biometry in these cases is routine. This is a patient from the Middle East who developed age-related nuclear sclerosis and had an anterior chamber phakic IOL in situ. I had to cut the lens and explant it in pieces. Adequate corneal protection using viscoelastic and maneuvers that avoid damage to the angle and iris structures need to be ensured. Routine phacoemulsification and IOL implantation followed. Phakic IOL is an elective, mostly cosmetic procedure and requires scrupulous care and attention to avoid complications.
Great. Lovely presentation, Dr. Jibina.
Thank you, ma'am.
Stop sharing.
Yes, yeah.
Dr. Chitran, I wanted to ask you a question. What is the lowest vault of the phakic IOL that you have left behind without needing to exchange?
No,
Nowadays,
I have up to 100 also.
100
Not causing problem, especially with the newer generation, ICLs. Even 100 is quite all right, but you need to assess these patients regularly, look for any changes happening, especially if it is a high myope, then peripheral areas should also be scanned. Sometimes you may have a touch in the periphery and localized opacity might come up. But with the newer generation, I'm not worried. Even 100 is okay with me. And I have hardly seen any cataract formation in these patients, even a 5-6 year follow-up in these cases.
So one of the limitations of ICL is the availability of only 4 sizes.
Yeah.
Now there are Indian companies who have multiple sizes at more frequent intervals. So in many cases, we have found that in spite of using the company nomogram, in spite of using the same size as recommended, we still end up having either a very high vault or a very low vault. So one of the important factors that has been mentioned is where exactly the foot plate sits. I mean, many times it has been found that it doesn't actually sit in the sulcus. So what are the precautions that you will take to see that it actually sits in the sulcus? Do you really know at the end of the procedure, are you sure that it is in the sulcus? This is one of the questions. Dr. Mahipal sir and Dr. Titiya.
See, the only way to be sure that it is sitting in the sulcus is for people like Dr. Titial who have intraopacity to kind of see that. Otherwise, there's really nothing. The only thing is the stability of the lens that you can see at that particular moment. But rest the foot plate can happen. See, there was one very odd case that happened in my particular circumstance. One of my colleagues had done. There was a shift in the toricity. Went ahead, did the redialing, and again there was a shift in the toricity in the angle. And lo and behold, what it was, I said we'll go and put in a bigger lens. So we got a bigger lens, and when we were explanting this lens, part of the haptic was broken. One of the haptics was broken. So that was the reason why the whole thing was shifting. So you never know. It is at times only post-operatively that you come to know that there is a shift, etc., etc. So we went back and put the same power lens and the same size lens, because it was not a fault of the sizing of the lens, but there was a small nick in one of the haptics which was there, which was causing the rotation. So to your answer, your question is that there is no way for you to find out. I don't know, somebody else may have. The stability of the lens on the table is one thing, and the second thing is to do an intraopacity to see whether it's sitting where it is supposed to be sitting.
I think
but where else?
Dr. Mahipal is saying is absolutely correct. On the table, sir, we can know the amount of vault in the central area. But to check the haptic orientation. Then in a post-op period, we have to do a UVM, especially
Yes.
in those cases where the IOL is rotating too much, or there is some sort of a difference in a position, shift of central area to one side. That can only be appreciated by doing a UVM to see exactly where these are placed. You are right, sir. Most of the times, one of the haptic may not be properly positioned. They may be entangled into the journal sometimes. So it's very
Yes.
difficult to have very proper set. The only thing which the surgery has to be little more predictable also. The way you put the haptic insides, let them slide down easily, and that can make a huge difference. There is no comparative study comparing the hydro injection from the visco related injections. So maybe I'm not sure which one will be more preferable, but as for a more predictable way, I think visco formation of chamber injection may be more suitable for most patients.
Heal on the way and have it getting evacuated right away.
Yeah, that's true.
So you can see how the companies change. They earlier said never to use Helon. That's when they started, right? And now they have come back to that it comes out as a bolus. But one little observation, I don't think there is any necessity to cut the implant that was shown by Dr. Ridhima. I think, you can actually.
So it was a rigid. I hadn't anticipated it to be an anterior chamber, like the patient. Like this is not one of the routine phakic IOLs that we use.
What
and it was
was
a
it?
very rigid lens, which I hadn't anticipated that. It was quite a while back that I had done that surgery.
Also, while all the videos were amazing, for the IPCL again, you enlarged the incision quite big. It wasn't required, right?
Not required, yeah.
Hand over hand technique.
2.8.
It comes with a smaller incision.
Yeah, basically a hand-over-hand technique is good. What I use is actually a smile forceps nowadays if I have to explant an ICL. That gives a very good grip and it is bent from the top, and then I use a capsular access forceps or a second to take it out. So a hand-over-hand technique, you can easily pull it out of the same incision.
Even the MST IOL holding forceps is very good.
That's
Does anybody use pilocupping after putting in the phakic IOL nowadays?
Only with IPCL sometimes, because like she showed the optic capture, if there's a high vault with the IPCL, there will be an optic capture and it will decenter the lens. So then sometimes I have to put pilocupping. Otherwise, next day I'll again see that optic capture.
Okay, one last question, Dr. Gaurav. In how many percentage of cases it has happened that the vault in the first eye is either too low or too high compared to what you had expected? And would you change the lens in the other eye?
I do it. I've done it a few times, and absolutely. See, it always happens in places where your ICL size is sitting on one side or the other. For example, like in 11.6, wide to wide, where you could use a 12.2, or you can, So when you're having that thing which is right in the middle, and sometimes you'll get a vault surprise. Especially if you're getting an oversized vault. Suppose you've used a 13.2 lens and you got a 1 millimeter vault, then obviously in the second eye you will not want to repeat that. So then I would definitely change it, because using the next size you'll get 0.5, 500 microns less approximately, or 300 microns. I can't remember. I've done that a few times and it works well.
So the message to the viewers is, if you have done the first eye, how many of us do both eyes on the same day? Because this problem can be avoided if you observe the vault a few days later and then plan for the other eye, so that you have an option of changing. I know Chitra ma'am would say both eyes on the same day, but
we also do both eyes same day. No.
We've not had any issues at all.
If you have intraoperative OCT, you can do both eyes on the same day.
we don't have. Assuming we don't have.
We've not had vault issues, full stop.
No, there full stop. There are no issues with ICL. Full stop.
No, I know. I'm not. You might see I become very good.
Chitra ma'am, I think you don't see your post-ops and somebody else sees all the vaults,
I see
and they don't tell you anything about it.
I see
Otherwise, it's not possible.
Anyone doesn't see post-ops.
I have had patients coming to me. See, let's not trivialize this procedure. I have had patients, the anterior capsule being ruptured or the interior capsule being damaged right on day one. And that was a very, very high-fi patient. And that patient in both the eyes, not one, in both the eyes, by somebody who went on to say that, okay, for an ICL, you don't need anything other than the microscope and things like that. So that is something that you need to be careful about. You have novice people without adequate training, even putting the lenses upside down.
Yeah.
So that So those are the things that
vault issues are.
You
vault
have
surprises are not uncommon. I mean, you know, it's
Yes.
not uncommon to get vault surprises, an unexpected low vault or a high vault, and I don't think we should trivialize at all. And definitely vault has to be kind of watched out for, otherwise there are issues that can happen.
You have to watch out for vault. Very rarely you would see a low vault. So very rare. I think we keep the right guys doing it. I mean, we don't allow all of them to do it, and bilateral is not being done by everybody, done by people in the main setup who are doing well. And anyway, I mean,
to be given to the viewers is basically check for the vault post-op and then evaluate for the second eye whether you want to continue with the same size or the one size higher or lower, right?
That's pretty correct.
And just one last question: till how many years post-op would you keep checking the vault?
You should check it on every visit, like once a year at least.
Yeah.
I would check it on every visit. I mean, not if the patient is coming in a month, but I think on day 1 post-op, and then, you know, at day 15 post-op, there's definitely going to be some change. And then, you know, annually at least you have to keep a watch on the vault, because as children, as they grow, some of them, the vault will go down drastically. I had a patient where it went down from 700-800 microns to just about 100 microns in 5 years. You know, so lens thickness can grow in some of these patients, and the eye can grow as well. So
Gaurav, my one question to you is: are we not getting cataracts nowadays?
We are getting significant numbers of. I mean, my 15-year-old patients are coming back with cataracts. So I would not be like over enthusiastic about low powered ICLs if I had an option to do laser correction.
Because I would say that maybe more than 70-80% of the cases are not mine. But there are a lot of cases that come to us with, all of us have femtolaser videos to show doing femtolaser with the ICL. So obviously the number of cases that we are seeing post implant of cataract are coming back. And obviously they say age is one factor, high myopia is another factor, etc., etc. But yes, you are getting these cataracts. So again, I am not in favor of trivializing the possibilities of developing cataract. Obviously, the companies will come out with the results which will say that there are no cataracts in this thing. Agree, V4 could reduce the incidence of cataract, but I have seen more cataracts with the Indian-made lenses than with the ICLs.
I think in a public forum like this, let's not make such sweeping statements, any of us. And it's always better to advise to be abundantly cautious. And I accept those extra things which are being told specifically for the youngsters not to go wrong. But I think otherwise...
So good preoperative workup, ventricular surgery, and good postoperative continuous monitoring is important. That is the message.
That's the message.
So let's move on to the last video. Dr. Raghav Malik, please start sharing. He's a consultant at CFS Hospital, New Delhi, and a very young, dynamic, brilliant surgeon. And he was the organizing secretary for IRSI just recently, which was a wonderfully done conference. So he's going to speak about vision loss in SMILE. Yes, over to you.
Thank you. Okay, good evening, ma'am. Good evening, everyone. Thank you, Anaga, ma'am, and Prashant sir for this opportunity, and my pulsar for these videos. So I'm showing a very short bouquet of videos of how to manage a suction loss during SMILE. So just one slide before I move on to my videos, just showing how we can manage suction loss at various steps during the SMILE procedure. So we can divide our SMILE procedure into multiple steps, going from the posterior or the lenticule cut. If we have a suction loss at the initial less than 10% of the posterior cut, we can always restart the procedure without any loss. If we have a suction loss more than 10% of the posterior cut, we can easily convert it to a femtolasic flap on the same Visumax machine. We just have to be careful to increase the flap diameter by 0.5 mm. That is a 7.9 to 8 mm flap should be made. Now, if we have a suction loss during the lenticule side cut, that is the posterior cut has been made, and during this side cut, we have a suction loss, we can repeat the side cut, but we should be careful to decrease the diameter of the lenticule by 0.2 to 0.4 millimeters. During the capped cut, that is the anterior cut, if we have a suction loss, these are the most tricky ones because we already have a pass of the femtolaser on the posterior cut. And once we have the secondary cut, that is the anterior cut, and if we have a suction loss, it is always difficult to see the center of the pupil. These are the cases where we can use the IR to actually see the pupil and redock and start again. But this, of course, requires a bit of an experience, and a novice would probably not be able to handle it. But yes, you can repeat using the iris registration. During the side cut, that is the entry wound, if you have a suction loss, which is very rare, but yes, it does happen. That is the last probably 3 to 4 seconds of your smile. If you don't have a cap cut, we can always redock and make just the side cut. We can, if we want, we can also change the position of the side cut, because if we have at the same position, we have to decrease the diameter of the cap. And we can always do a circle after suction loss. I'm going to start my video. So this is a suction loss during the posterior cut, which is more than 10%. So we go on to dock, and here we see we have about 50 to 60%. In such a case, we can redock and convert this into a flap. The flap, we have to be careful, should be 0.5 millimeter bigger than the optic, that the total zone, that is of 7.9 to 8 millimeter flap should be made. Once a flap is made, it's pretty easy to lift it up and do the eximo. Of course, we also have to talk to the patient, and we know that the patient has paid for and has agreed to a smile. We do tell the patient, we do take a verbal and written consent that we are changing the procedure from a smile to a flap, because the patient was agreed for a flapless procedure, but we are now doing a flap procedure. Now, this is another video showing a suction loss during the side cut. That is, the posterior cut has completed, but during the side cut, we can see the bubbles at the lower part, and lo and behold, we do have a suction loss here. And just as the side cut is being made, in such a position, we can redock, and we have to decrease the diameter of the cap, and we can redock and make the side cut and start from there. This is a suction loss during the anterior cut. Like I said, this was the most tricky part, because once we have the posterior cut, pretty smooth. Now we have the side cut. Now we see the laser is passing through the cap cut, and we can see the bubbles, and here we have a suction loss during the anterior cut. So such cases are difficult because we have two passes of the laser. So the OBL comes in the picture, and we cannot. So here with experience, we can see with the IR, we can see that the center of the pupil is there, and we can redock and start the anterior cut again. Of course, once we do the lenticle procedure dissection, there can be some difficulties because there is about 3 passes of the femto laser. So it can be a bit sticky, but it is not something that cannot be handled. We go in, open the main cut, main wound, and find the anterior plane. And the posterior plane. We go into the anterior and start dissecting. This one was pretty smooth. And go on to the posterior cut. This is the posterior cut. And once the section is done, the lenticule can easily come out. It's a bit sticky, but yes, the lenticule easily comes out. Now, this is a suction loss during the entry cut. That is, the posterior cut has been made, the side cut has been made, the anterior cut has been made. The last 3 seconds, that's when we do have a suction loss. So routine docking, we do have the posterior cut, the side cut, the anterior cut, and just as you see, suction loss, so we could not make the main wound. We have tried making the main wound manually with a crescent or probably another side port, but that is not too good for the cornea. We can always redock and make the main wound. We try to decrease the side of the cap, and once we have the main wound, we can find the anterior plane. So we have to try and increase, that is, we have to decrease the diameter of the gap, and that is, we don't want the new cap, main wound to be at the same location as the previous one. Once that is done, the lenticule easily comes out. Of course, we can always do a circle scan after a suction loss. This is a case where after suction loss, we do a circle scan. That is, we can convert the cap into a flap. And once that is done, it is pretty easy to just lift up the flap. Our main wound is incorporated inside the flap. And you can see, pretty easy. And we do an excimer, and that's it. Thank you. But before I end, I must discuss what should be the possible causes of a suction loss during SMILE. Of course, we know that the suction in this VisuMax is not too high. That is, the patient is seeing, and we are using the patient's vision for fixation. So the patient is looking at the central green light. So we know that the patient can have sudden and jerky movements. That is the most common. We can have loose epithelium. We can have excessive fluid. We should always have a moist cornea. We don't want too much liquid in the fornices. If we have a deep set eye, there can be pooling of fluid. And if that is there, we can always have a suction loss. And also loose conjunctiva can give us a pseudo-suction. And that during the laser procedure can always have a suction loss. Thank you.
Just wonderful presentation, Sagar. There's one or two things which I wanted to add, Anaga, in that. Supposing you see the conjunctiva is encroaching and you have not yet, the entry cut is going to start any moment, you can actually take your foot pedal off so that before that it is done, then you can redock and do the anterior cut, because manually doing is actually not a great option at all. The second thing I wanted to say was aligning it on the same OBL is also very important.
Very
difficult. The third thing I've seen in my experience is those very few regressions which have happened in SMILE. SMILE, largely regressions are very minuscule, less than 2%. I have seen it happen coincidentally in those cases when there has been a suction loss. So intraoperative suction loss can cause somehow the wound healing mechanism is altered, and there could be a regression rarely. Not all of them, rarely.
Is it a regression or it is an undercorrection to begin with?
Why would it be an undercorrection? You have removed the entire...
No. I mean, what happens is that sometimes when you have an impending suction loss, your planes may change. That's, I don't think that if you've gone through with the whole procedure and everything went off well, I doubt there will be more regression.
Why should there be regression? In any case, Gaurav, I would want to... I'll want to contest what you are saying is that basically, see, one important thing that has come out of your comment is that we should use the same patient interface. You don't need to change the patient interface. The machine automatically takes you back there. And once a plane has been created, the plane, the OBL, the fresh will go into the same plane. It is not going to create a new plane. That is the biggest advantage of a femto laser, whether you are doing a flap or you are doing a lenticule, whatever it is, that you go in the same place where the plane has already been created. So you don't create a new plane, otherwise you will get slivers. And the other important thing is that why you are able to do the recut of a lenticule in Zeiss is because it's a plano-convex lenticule. It is only because the posterior surface is plane. That is why you can go ahead and do it. But in a biconvex lenticule, as we are going to have, as we have in silk, you cannot do a rescue mechanism. You will necessarily have to convert it into a flap. PRK or a flap. You can easily convert it into a flap if it is while the undersurface is being cut. That means the posterior is being cut, and then you have still not gone onto the anterior one. You can convert it into a flap. Otherwise, you can just abort it and do it later. But one of the biggest advantages is that in the ELITA procedure, the suction is very strong, and we have not had any case of suction loss so far.
Yeah, we've not had it in clear also.
Yeah, so that also because it's a strong suction in that. The other thing which Raghav, you were mentioning about the suction loss thing is that the time duration now in the VisuMax Pro has gone down significantly.
Yes, sir.
So that again, because the time that a person between his losing the sight of the green blinking light and the rest of the is gone down significantly. Yeah, so therefore, as Sonu and all were saying, obviously the lower the time, the less the chances of suction loss.
Yes, sir.
I wanted to ask if anybody has attempted a smile after, the lenticule cut was aborted, like more than 10%, because we have done a couple of cases and it's come out really well. What we do is that we ensure that we are keeping a cap of more 120 or more. So what happens is that if you do occasionally, you get a rare, posterior cut suction loss, you can just change your cap diameter thickness to 90 microns, more than 30 microns different, and even maybe decrease the optical zone by 0.1 or 0.2, because then the lenticle thickness will come down, and then you can still go ahead with smile, and you don't have to convert to a flap.
Sorry, I didn't get you. You are making the from a 110 or 120 you are having instead of 110, 120. No. If you had 120 to start with, then you will go to 90. Is that
90
what you're
or
saying?
100, depending. You want a difference of at least 20 to 30 microns between the initial cut and the second cut.
Okay.
So we
I haven't tried it.
Like that, and it comes out really well, and we could still offer the continue with smile rather than convert to flap.
So you mean to say a 20 micron difference between the first cut and the second cut would not cause any
ideally 30, sir, but in one patient we
Okay.
did get away nicely with about 20 also. So there are two ways to decrease that. One is to, of course, change the cap thickness down by whatever you can, and then other is that you can decrease the optical zone by 0.1 or 0.2. That also gives you slightly thinner lenticule than before, so your cut will happen slightly more superficial.
Okay, so you're reducing the optic zone. Okay.
Anyway, these things hardly happen. So
when it happens, these things come in big handy,
Yeah. They happen to us, right?
Not to Dr. Chitra.
Not now. Now
we are still beginner surgeons, ma'am.
No, because once you stop operating, so it wouldn't happen, right?
No point talking to you. You're just so completely unreasonable.
How can they not happen? See, these
doesn't happen
things.
much because maybe I talk a lot more to the patient and give the attention. Maybe the counselors outside are keeping them relaxed. It's one not stressed patient only.
I think Shreyas gives you all the easy patients to do, and then he picks all the difficult ones.
No. I don't think suction loss happens much in your hands either, but you are in a mood to just rag me, so you should close the whole thing.
Okay, I think it's dinner time, and for Gaurav some other time. So let's just close it, right?
Gaurav, you should switch off.
Prashant appeared for a moment. We should say hello to him also before we close.
I don't know where the moderators
are. Gone for dinner.
Prashant is
there. Chalo, bye.
Prashant didn't want to learn a new subject, and all together.
No, he's been around all the time and listening to us. Yeah.
Thank you everyone. In fact, I was listening and trying to understand what it means with all these flags and all, but still it went as a bouncer for a retina surgeon.
Flags कहाँ से आ गया यार? Flags कहाँ से आ गया?
Sir, refractive जो भी आपका जो भी है हमारे लिए terminology.
Okay, great.
But I think very good talks today, and Dr. Anaga, very nicely planned webinar. It was really useful. I learned a lot. I enjoyed myself so much. So
very nice.
We enjoyed good discussions.
Yes, we did enjoy ourselves. Yeah, great.
Very good presentations.
Very good presentations.
Thank you, everyone. Thank you on behalf of ARC for being with us. Anaga, you can just wind it up. It's already over.
Thank you.
Hello.
I don't